That was a great TV show.
I love Palladium.
Good evening. It's now 7 p.m. and I'd like to start the virtual meeting of the Health and Wellbeing Overview of the Scrutiny Committee. I would like to remind everyone present that this meeting is being live streamed to the Council's online webcast channel. I'd also like to remind members and officers to mute their microphones when I'm not speaking and to use the raise your hand option when you wish to speak. I will give everyone the opportunity to speak at the end of each item. Can I ask all members to turn their mobile phones off, electronic devices, tablets, music, etc. to be on silent during the meeting? I'll just throw my phone somewhere so they can't go off. I forgot about that one. Okay, item 1. Apologies for absence. I've received apologies from Kim James. Have we have any other?
No, Councillor Ralphs.
No, that's good. Item 2. I move to the minutes for the Health and Wellbeing Overview Scrutiny Committee held on the 5th November to be approved as a correct record. Does any member have any comments on these minutes?
No hands up, Councillor.
Sorry,
Oh,
yes,
no,
I've got
sorry,
my hand
Councillor
up,
Maldowney.
Yes, Councillor Maldani.
Thank you, Chair. Yes, I just note that at the last meeting, the Chair said that he may be writing perhaps a joint letter with the portfolio holder for health about the money that's owed back to us from Peterborough. I just wondered, had that happened? Did that happen? Also, I think we were going to have further discussions. Mark said that somebody would be here tonight to discuss that, but I don't see it on the agenda. So are we going to do that tonight? If not, when are we going to do that? And there's been repeated requests now to deal with this issue, and it's really unacceptable that it's not coming back. I know we're in the middle of a COVID pandemic, but even so, I think we need to move forward with this.
Yeah, we have had discussions. I don't know if Roger could come in and just give me that update that you gave me the other day regarding the funds.
I think this is one I'd love to answer that one. I'm afraid I'm going to pass this one to Mark to answer.
Thank you, Roger. So I think the letter that was sent, I think before Christmas, I think in fact for the November HOSC meeting, kind of set out the position really, which was that there was a commitment made for the return of the £480,000. What has transpired is that in subsequent times, more money through various mechanisms has come into the Mid and South Essex system, far in exceeding that £480,000. And in the round, more money has come into the system than has left the system. And the particular issue that the committee was rightly concerned about in terms of delay in the opening of the crisis service mental health didn't materialise. So I think in summary, I think there is a kind of sense that that from my perspective, we have kind of pursued it. My finance officer has been in dialogue with the region, but that is the position that the region are taking. I guess from my perspective, I think that the issue is that the committee were kind of made a promise, and they kind of feel like a promise has been broken, and that's that's problematic. I think materially, in terms of money coming into the system, I think you can see that that funds far in excess of that £480,000 have come into the system and have benefited the patients and population of Thurrock. But I think the expectation of the committee was that there would be a direct transfer from Cambridge to Thurrock for that proportion of money, and it has not happened in that way. I think the letter does allude to also the fact that NHS finances are quite complex, and they're, as a system, we do also run in deficit, and we do, we overspend on our allocations, not as a CCG, but that's more where the problems sit, rather than us actually also kind of being able to say that we are, living within our means too. So I think that is also kind of further context that is alluded to within the letter. So I think from my perspective, I'm not sure where else I can go with it. I think the kind of letter sets out the position from the region. We have pursued it as far as I think we can, and I'm not sure. I'm not sure what else I could do, if I'm honest.
Thank you, Mark. Can I bring Councillor Holloway?
Well, okay.
Sorry, Councillor Danny. Did you want to come back on that?
Yes, because I'm not clear. Are you talking about the letter that we already had before the last meeting? Because it sounds as if you have, but I'm not quite clear. We were told that we would have somebody at this meeting to answer these questions. Also, I'm not clear about what money's coming to the system, because I've had no details about what money's coming to the system. All I know is that we were promised to have this money paid back. I don't know if the extra money that's come into the system was that to cover COVID costs, or is that extra money that's come into the system to cover the loan that we had to give. It's not clear at all. Did the letter go from the chair and or the portfolio holder from health from the last meeting, as was said at that meeting? If so, is this another letter that's come back? I'm not clear about any of it. No,
I can clear the letter issue up for you. We actually had a video call to discuss this on a face-to-face basis, where we put our portfolio holder and myself put our case over that we felt we'd been made a promise and it was broken, which I think we all agree that we do feel that. I do understand what Mark has said in the terms of how much money has come back into our area from that money, which is more than what was taken out. What I don't see, Mark, is any evidence that if we can have that in some sort of paper form to show that. I mean, I know from your side that they feel that you've paid it back in enough and plus, but I say it's not gone with the guarantee that we thought that we agreed to when the money was taken. I don't know, Councillor Madani, I mean, how would you like to, if you sort of can email me what you'd like to proceed through, would you, and Councillor Holloway, if we could get a statement from Mark stating the breakdown of the figures and how things back, would that satisfy yourselves?
I would like to actually have things done as was requested by the committee and as was agreed by the committee at the last meeting. And I would like that to happen. And not whatever this other thing is that's happened, which wasn't agreed by the committee. All members actually agreed that we should have an update before this committee meeting. We wanted to have an update before this committee meeting. So why didn't we get an update after even you'd had your video meeting? I mean, I understand we're in a pandemic, so I'll let you off the fact that we haven't had an update before the meeting, but at least there should be an update at this meeting with people who are able to actually answer the question.
I appreciate that, and you raised some good points, Councillor. As I say, unfortunately, Mark's seen me far too often recently with other issues with the COVID, so I know the situation that they're in. I just want to bring in Councillor Holloway.
Yeah, thank you, Chair. Keeping on that, I would say I agree with Councillor Muldowney that when the committee has made a request, and I do appreciate, Councillor Ralph, that you and the portfolio holder have had this conversation, and thank you for having that conversation. And with Mark, I think, I'm sure that you would also like this money to come back. So I know it's not, I'm sure you'd like more money than what was taken from us. So I understand that you're probably making representations on our behalf as well. As Councillor Muldowney said, we agreed as a committee that a letter would be sent So I think that letter should be sent, even following your conversation, so that that can be shared with the committee and that we can get a written response back outlining all those issues. And as Councillor Maldoni said, we were told that we were going to have someone here to answer the questions. It is absolutely unacceptable that as a committee we are assured that we will have a representative, that we will have a written report and an update. Those are the three things that were assured to us as a committee. Now, I agree with Councillor Maldoni that it's a pandemic, so much is going on, but on this issue, there are some things that need scrutinised that can't be put off because of a pandemic. This is one of them. I go on, Chair, that we're looking at an item in this agenda tonight where we are charging people more money for services because we don't have enough money. We need to be charging people, yet we are not continuing to fight to get our money back. Now, I would like to have that letter written, to have a representative, the finance officer, as was promised at the March meeting, to answer the questions, and then following those questions we can then decide as a committee what strategy we'd like to take. I will not accept the excuses that have been provided so far. That's that. I'm not accepting it. I want to speak to a finance officer. I think that should be written.
Okay, thank you, Councillor. Councillor Vettel.
Thank you, Chair. Yeah, I actually agree with Councillor Holloway. I think that it's fine to have all these meetings on Teams and Zoom and whatever, but when something's written down in a letter that's got to be answered, it's a bit like an email, isn't it? If you send that, you've got some form of something has got to come back to you because you sent that in. It's money that should be paid back, is right. It's money that should be in our coffers and not where it is, wherever it is now. We should have somebody to scrutinise, because that's what we are. We are a scrutiny committee. And if we're just laying down and saying, oh, that's all right, walk all over us, that's fine, that's not the case. We've got to do, I don't want this to be taken wrongly, and I'm going to be very careful with my words, but there's too many things now that's because of COVID. We can't do this. And I'm sorry, we can't blame COVID for everything. If we're not going to do that, then we don't do overview and scrutiny, because it's not working. And of the same vein as Councillor Holloway, I think a letter has got to be put forward. We have to have an answer back, but we also need somebody in front of us that we can scrutinise. What's the point of us being here? No point.
Okay. Councillor Massey.
Thank you, Chair. I'd just like to agree with other members of the committee. I think we need a written response to this and to have someone to come to one of these meetings for us to scrutinise. It's been going on for many, many meetings now, and I would like to draw a line under one way or the other, but I think we need to go through this process and then agree the next steps as a committee.
Thank you, Councillor. I mean, what was more confusing is that we both received, I know the portfolio holders see a different letter than what we received, which sort of was quite confusing. So I wonder if we can get, well, we will ask for some to be here in our next meeting. I do agree with the other councillors. I will get the letter sent for you. If we do that as a committee, or with the joint portfolio holder as well, to ask that. I guess I'm expecting what we'll get back, but you're right, a promise was made and I don't think it was kept to. It wasn't kept to. I would like to see a breakdown of the figures that were brought back in, an explanation of how they felt that covered what was taken out as a loan that wasn't repaid. Councillor Holloway.
Thank you, Councillor. I assume, sorry for my delay, the tech wasn't working. Are we on the accuracy of the minutes and matters arising?
Yes, we are, yes.
I'll address those now, thank you. Just a couple of things, one on the accuracy and one on matters arising, if I can take them together, Chair. Yep. The first one is page 6. Sorry I didn't do this before, Jenny. I know I should have. Tiny typo. Just page 6, bottom last paragraph. It says the paragraph, if appropriate, it said Councillor Ralph had said. Oh no, actually that's not right. I thought that said something else. Oh, I'm wrong on that one. Sorry, Jenny. So nothing wrong there. The other one is, rereading that back, that's what happens when you read it quickly, is on page 20 on the work programme. It said members reviewed the work programme and agreed. With regards to the refuges and safe houses for male victims, we didn't actually agree that to come back onto the work programme. I've got no problem if anyone wants to suggest it comes back on the work programme, but we actually did not agree it wasn't discussed under that item. I think we just have to be really careful that we need, when a member's agreeing something and aren't agreeing it. So if Councillor Ralph wants to bring that back up for the work programme this evening for us to agree, that's fine, but that actually didn't happen at the last meeting. And then on matters arising, Councillor Ralph, you won't be surprised that I'm questioning about the financial report that I had brought up a couple of times and had emailed you about. Obviously, just wondering why we don't have that financial report this evening.
We will be coming on to that when we come to the fees and charges. We'll cover that quickly for you.
Okay, a quick cover up on a fees and charges. I'm sorry, just wasn't the request and isn't acceptable.
I'm not going to spend much time covering this now.
Okay.
It's for a corporate scrutiny committee to go over the budget of the full council, not for health and wellbeing scrutiny, and that is basically the end of the matter on that.
Okay, yeah, no, thank you for raising that. The other item that I wanted to discuss on matters arising were the items on the work programme from last meeting in November. There were a number of reports that were on the work programme that were supposed to be discussed this evening. Whilst you say about the detailed financial report, which, you say it shouldn't come, there is supposed to be a detailed fees and charges report and an adult social care fees and charges pricing strategy report. Both were on the work programme in November. Also missing the strategic safeguarding plan, a worklessness and health JSNA, personality disorders complex needs report, and the whole systems obesity strategy, delivery and outcomes framework, alongside the request, obviously, for the report with regards to the money from Cambridgeshire. None of those are on the agenda this evening. I want to know why. The finance reports, that will mean that fees and charges report, which should come to every scrutiny meeting, there has been none for the whole year. Two of the reports have been pushed to the 2021-22 work programme. Where are the others and why have they been removed? Thank you, Chair.
Roger would like to come in on that one.
All I can say is that I don't want to, I'm very conscious of what Councillor Redsall just said about blaming COVID. I don't really want to do that, but however, it is true. We've had to re-profile some of the work programme into the March meeting and into the municipal year because officers, quite frankly, have done nothing but dealing with COVID the last 3 months. And I apologise that some of the reports were not ready for this meeting, but it just has not been possible to produce the reports in a state that we will be comfortable for this meeting. So we've kept the meeting tonight quite light. There's going to be quite a big discussion on COVID and some other matters that were thought to be important, but unfortunately, officers have not had the time to prepare those reports for this meeting tonight.
Yeah. Could I just come back briefly, Councillor Ralph, just on a couple of specific things there? I completely understand that. I don't think that it is that is a very chunky agenda. I understand things move. However, there've been no fees and charges written report to the scrutiny. That has to come to scrutiny. Where that's missing, it's unacceptable. And I would like to know where the items that were on the agenda have gone. They're not even on the work programme for next year. That is several items that has been pushed that is not now accounted for. I understand that there might not be time, but where have we decided that worklessness and health JSNA and the strategic safeguarding plan aren't even on the agenda for 2021-22? We do have to have a level, as Councillor Redsall said, of scrutiny. If we're not doing that, what's the point in having these meetings? And Chair, I do say that you are responsible for the agenda as well, and ensuring that the things that need to come to scrutiny are coming to scrutiny. So whilst I understand officers' pressures, you need to, as Chair, know what needs to come and what doesn't. I am really disappointed that lots of this isn't on the agenda.
No, I mean, I appreciate that from your side at the moment, and we haven't got a vice chair that would actually be privileged to information as well, that we have been sitting on committees and the COVID board. It has been, if I'm going to say is that they've been working all over Christmas, over everything. I've never seen a load of people work so hard to the edge of the point of cracking. I don't want to keep pushing down that COVID has caused a lot of problems. I do agree that some, obviously, things have moved and shifted. I understand that the reports, when they're finished and ready, they will be put back onto the agenda. And I think that is just the agreed state that we're leaving it. For tonight, we do have to have some important conversations over COVID. So it was agreed that this would be a shorter agenda, but quite in depth with context when it comes to what we are talking about. I don't know if Roger wants to come back on any of that at all. Oh, so you're on mute, Roger.
I was going to cover the fees and charges. The only proposed change in fees and charges is around domiciliary care. So there are no other proposed changes in fees and charges. And in fact, domiciliary care makes up 90% of our discretionary fees and charges. All I could say is that we will, all those reports that Councillor Holloway has referred to will be coming back to committee. I know the worklessness report has been is in draft, and I know Ian's team are working on that, and some of the other reports in terms of obesity, again, also Ian's team has been working on that. But I have to say, there is at the moment, because the public health team has virtually been doing nothing but COVID the last 9 months, it hasn't been possible to produce those reports for tonight's meeting. So I ask for some forbearance with members, but we will, if they don't come in the next meeting, they will certainly come early in the new municipal cycle.
Thank you, Roger. Councillor Little.
Thank you, Chair. Yeah, I only really wanted to say that I have not got an agenda. I have read it. I'm not sure I understand. Don't know what that is. I don't know what that noise was. I really don't. Yeah, I haven't got an agenda. I have read it, but we can't even bring it up on our phone, and I can't halve my screen. So it's just a point of listening and doing everything. I just wanted people to know that with the post the way it is, we haven't had any post for a month. So, okay, thank you, Chair.
Yeah, I appreciate it. Councillor Holloway, did you get the agenda okay?
I did. I've obviously been very lucky with my post. I do know I have had lots of residents contact me, and I know it is a bit hit and miss, but luckily I do have a paper copy. But I am aware that Councillor Muldowney, when we spoke earlier, she hadn't got hers in the post. So yeah, I can imagine trying to use your computer to look at the agenda and keep an eye on everyone is quite tricky. So yeah, we'll bear that in mind. Another difficulty for chairing this evening.
Councillor Muldowney.
Yeah, I was just going to say that I haven't got an agenda, so I am trying to. I've got my computer. This is why I'm here. I've got my computer in the background, but yes, I can't go by page numbers because obviously there's no page numbers on the computerized agenda. So if people could say what reports that we're looking at, and I don't know, maybe paragraph numbers, that might help. But also, I think I'm a bit. Are we going to put these missing reports at least on the next municipal year's agenda on the work programme? Can we at least resolve to do that?
So I think we just need to be a little bit flexible, because again, I can't some of these I can't guarantee that we will be in a position to produce them for the March meeting.
No, that's why I said the next municipal year.
Absolutely fine. If we can keep a track of them, I absolutely guarantee they will come back. I just can't guarantee which meeting they'll be ready for, but certainly keep them on the long list. Put it that way.
Yeah. Thank you, Roger. We'll have to add it onto the long list. Okay, that's the final that one. Where are we now? Item 3, urgent items of business. I've not agreed to any urgent items of business. Item 4, declarations of interest. Does anyone wish to declare a declaration of interest? Nope. Okay, item 5 has been removed due to Kim James not being attending, unfortunately. Okay, item 6, COVID update. This item will be in 2 parts. The first part will be current, I can't say that word, epidemiology provided by presentation from Ian Wake. The second part will be a verbal update for the announcement of the major incident over crisis and the new year from Mark Tebbs and Anthony McKeever and Roger Harris. Can I ask Ian Wake to introduce his report, please?
Thank you, Chair. It's not a report, it's a PowerPoint, I'm afraid. The problem with writing reports on epidemiology is that by the time you've written them, they're out of date. So with your permission, if I can just share my screen. Can you all see that?
Yeah.
Yes. Yeah, okay, super. Okay, I'll try and keep this as brief as possible. Our overall rate as of yesterday of positive tests per 100,000 population was 1,334.7 per 100,000, which is that green checkered bar in the middle of the chart. Thurrock was ranking out of all upper tier local authorities in the period just up to and after Christmas highest in the ranking. You can see here's the ranking at the moment, so we've dropped from highest to 5th, but obviously still a very high absolute rate. As members will be aware, we saw our rates rise considerably with the emergence of the new variant of COVID-19 that is far more transmissible than the original wild strain of COVID-19. We need to be slightly careful in assuming that these rates match our underlying prevalence of COVID perfectly, because they're obviously also a function of the number of people that we are testing. And to try and control for that, you can look at something called a test positivity rate, which is the proportion of the tests undertaken that turn out to be positive, and that's shown in the little black dots. So you can see Thurrock has the 5th highest overall rate, but our positivity rate, the proportion of COVID tests that are positive, are dots. It's about 22% at the moment, which is still high, but not as high as some of our other nearest neighbours, which have rates moving up to kind of 30+%, which is quite extraordinary, really. I think the other thing to note is that you can see, I mean, this is a ranking in terms of the local authorities with the highest rates. They're all really centred around our geography. So North East London, South Essex, or North West Kent. And that's where this new variant actually originated from. And this is the latest test data. So this is absolute number of tests and absolute number of positive tests. The red bars are the absolute number of tests undertaken. The blue bars are the number of positive results. So you can see we had a surge in demand for testing, the red bars, and the run up to Christmas, that first peak that then fell back over Christmas week, and that was a effect that was seen, I think, right across the country. And then more recently after Christmas, we've seen an increase in demand for testing, so the second peak on the red bars. On the blue bars, although we've seen an increase in demand for testing, we've actually seen the number of positives drop off. And the black solid line on the left-hand side is the test positivity rate again over time, so the proportion of tests that were positive, and you can see that line falling. Taking all of that data in the round, my sense at the moment in terms of what's actually happening in terms of our underlying community incidence and prevalence is that it's plateauing. And I think that is good news. It's plateauing at a high rate, so I don't want to mislead committee into any sense of complacency about this. But whilst I think in the last couple of weeks we were concerned that the epidemic was increasing, I think there is some promising signs at the moment that actually the measures that we have in place are at least now keeping community transmission at a stable rate. One thing that has changed over the last few weeks is the age groups in terms of where most positive tests are occurring. So in the week up until the closure of the schools before Christmas, the age group with the greatest number of tests were the 10 to 19-year-olds, as we knew that the epidemic locally was being driven very much by secondary school children. That shifted as the schools closed for Christmas and then have only partially reopened for the new spring term in terms of children attending on school site. The age groups with the greatest number of positive tests are now very much, as you see on that graph, working age adults. So the age groups 20 to 59. This graph shows the spread of the epidemic across the borough. I wouldn't want you to read too much into this. So the darker the blue area, the greater the number of unique postcodes with a positive test result. However, I think what I'd like you to say from this graph is actually that we've got sustained community transmission actually going on in all parts of the borough. There are very few lower super output areas, which are kind of sub-ward level, that have fewer than 10 unique postcodes with a positive case. What we are seeing across the borough and actually across the entirety of Greater Essex with the new variant, the much more highly transmissible variant, is a issue in terms of care homes. So we have a significant number of our care homes in a live outbreak status or a live exposure status, which is one case rather than a cluster of cases. More positively, we've seen, as you saw from that last graph, a significant reduction in activity in education settings as more children are accessing learning remotely from home. In terms of what's happening at the hospital, I'll leave health colleagues to expand on this in more detail. But you can see this is hospital bed usage at Basildon Hospital in terms of COVID patients. You can see a rapid increase really from about mid-December as we have the emergence of the new variant. From around, I guess, the tail end of Christmas week upwards, you see those numbers continuing to creep up, but at a slower rate. As members will be aware, the system declared a major incident, I think, on the 27th of December, and there has been an enormous amount of really good coordinated partnership working to try and stabilise and shore up the health and care system across Essex. And that has had, I think, some effect in terms of slowing the growth rate. My sense, again, is that the next week to 10 days are going to remain very challenging for our health and care system because there is a lag on what happens in terms of community incidents and what happens in the hospital. But hopefully, if we can see the community incidents continue to plateau and possibly start to fall, that will eventually play through to the hospital. So in conclusions, I think there's some evidence that overall prevalence is plateauing, albeit at a very high level of incidence. There continues to be widespread community transmission across the borough and beyond it. Positive test results are most concentrated in the working age adult population. Demand on hospital beds continues to increase, albeit at a slower rate than before Christmas. The local health and care system remains under significant pressure, I think particularly intensive care unit capacity. The new variant unfortunately continues to result in high numbers of outbreaks in care homes, much harder to control it once you get one case in a care home. Hospital bed use due to COVID continues to increase, although the speed of that increase has slowed. And I think in terms of our key priorities moving forward, We launched this week, I think, to great success, actually. We shifted the focus of our community screening from secondary school children and their families to working age adults. We have had some data back from that already. We have been handing 1,500 plus actually tests out every day on the first 2 days. So I think there's been a really positive response to that. So the more people that we can identify within that population and get to self-isolate, the better that will be for the epidemic. My colleagues will come on to talk about the huge amount of effort around continuing to stabilise the health and care system. And ultimately, as we all know, the best route out of this is vaccination. Again, there are some valiant efforts going on across the borough to roll out the vaccination programme at pace, and I'll let colleagues pick those up in more detail. Thank you very much.
Thank you, Ian. We've still got your screen on. Thank you. Much appreciated, Ian. I mean, I know I've been privileged to your updates over weekly since before Christmas, and it was scary. I must admit, some of the meetings we've had, seeing the figures rising up before Christmas was a great cause of concern. And after, with the flood, we was worrying about how the hospitals were going to cope. So there is a bit of, I don't want to be, say, overexcited, but cautious about it plateauing. I really do hope that this is the start of seeing a drop of the numbers in our areas. Okay, I'll bring in Councillor Retzel first.
Councillor Raff, I'm not sure
Thank
if you
you,
wanted
Chair.
to do the other presentation first before you did questions, perhaps?
No, I actually just break it up into Ian, then Rogers, and Mark, Anthony's. Councillor Retzel.
Thank you, Chair. Just a few questions, Ian. I think I'm glad the Chair said that, because you could go on and you could forget what you have. Wrote mine down, but you said about the 12 care homes that have got live outbreaks. Does that mean that those care homes have not had the injections at all? That's just one. The new variant in care homes, how has that got into care homes if they've had no visitors? The new variant, it just seems funny to me that that has got into care homes when they weren't getting any visitors anyway.
Okay, so on the first one, sorry, what was this, the first one?
The 12 care homes got live outbreaks. Why haven't they had the injection?
Oh, right. Yes, sorry, on vaccination. So we are rolling vaccination out to care homes, to both staff and to residents. I know that I haven't got the exact numbers in front of me. Roger may have more details, but I know we've had a quite considerable vaccination push in many of the care homes. So a lot of residents have been vaccinated. Obviously, if someone is positive within the care home, then they can't have the vaccination. So that's the limiting factors. The other thing to say about the vaccination is that it doesn't provide 100% immunity from the point of the first dose. So it will take about 3 weeks from the first dose to get the immune response. And that will give you, after 3 weeks, a level of immunity. The second dose will give further immunity, but no vaccination will ever give 100% immunity. And so I think hopefully that answers your first question. In terms of how it's getting in, the obvious answer is because of staff, because staff have to come in and out of the homes. We are doing everything possible to try and mitigate that risk. So the government tests staff once a week through the National Care Home Portal. We have gone over and above that in Thurrock, so we are testing staff with a PCR test, so the really accurate tests twice a week. So we've commissioned Comissio again to come in. So staff are getting a COVID-19 test between every, about every 3 and 4 days, which is about as much as you can do. But regrettably, with this new variant, it's still not possible to pick up and isolate everyone quickly enough. So we're doing everything we possibly can I wouldn't want you to think that the outbreaks in Thurrock care homes are any higher than elsewhere. This is, again, regrettably a phenomenon that we're seeing nationally with this new variant. It is just so infectious.
Thank you, Ian. Cheers.
Ian, just before I bring Councillor Madoni, the tests that the care home do, are they the lateral flow ones? Are they still doing the full test?
No. So again, the government have made lateral flow tests available for care home managers to test staff, and they can use those if they want. But we have gone over and above that. We've got the full PCR happening twice a week because they're much more sensitive tests and much more likely to detect COVID. So we're not just relying on the lateral flows.
I mean, one of the major questions that I keep getting asked, why aren't staff being able to test themselves at home? But I'm right to understand that the lateral flow tests have to be done by a trained officer. Is that right? As some
So the MHRA license for a lateral flow test doesn't allow it to be done at home at the moment. I know this is something that is being considered. The reason that's not been allowed to date is that actually the lower the level of training of the person undertaking the swab with a lateral flow test, the poorer the accuracy that the test becomes. They're not. Yeah, if you have a highly trained nurse doing it, it has a sensitivity of about 77%. If you have someone that has less training, it drops to about 50%. I think if you were allowing people to do it themselves, it would drop further. So that's the thinking so far.
Is there a risk of us putting overconfidence in the lateral flow test or being forced to put confidence into it?
I think with any test, you need to think who you're testing, why you're testing them, and what the consequence of a positive result and negative result is, what you're going to do with that result, and what's the risk that of getting a false positive or a false negative. So I think if you're using lateral flows in kind of general community screening to test people that you otherwise wouldn't test at all, then finding some positives is better than finding no positives. But what I wouldn't want to do is use them to rule out COVID in a setting like a care home, where the consequence of getting that decision wrong could mean very vulnerable people were infected. So I think there's no simple answer to that question. It very much depends on the context, the setting, and the consequence of getting it wrong.
Okay, thank you. It's very encouraging to see the uptake of the working age tests.
Sure.
I know that in my local area we've been encouraging them as much as possible, and to hear that sort of 1,000 a day are being taken, I think that's brilliant and a major way ahead. Councillor Madoni.
Thank you, Councillor Ralph. I suppose last time we were here on the 3rd of September, obviously we were well down the list through, I think we were about 106 out of the 149 upper tier local authorities, and sort of now sitting here, hopefully having been through the peak for us for this wave, but seeing those numbers and us go to number one on that list sort of before in sort of mid to late December and over Christmas was very scary, as Councillor Ralph said. So I suppose sort of my questions are, what happened? How did we get from sort of about 5 cases, I think there was last time we met, and to such a high level so quickly? And sort of maybe more saliently, do you think there was anything we could have done differently to have prevented that? I'm just thinking that there was a time where we were in tier 1 and the rest of Essex was going up to tier 2. Would it have made a difference if we had have gone up to tier 2 at that point, or is it that the tier systems just weren't a strong enough intervention to actually stop the progression of the disease or the new variant that came into play?
So the answer to your first question is the new variant, and the new variant changed everything. I think it caught everyone by surprise. As you rightly say, Thurrock had been towards the bottom of the rankings throughout the entire epidemic, really until December. And I would like to think, although I can't prove it, that certainly our local response and the behaviour of our residents had something to do with that. what happened, the new variant, we're not entirely sure where it came from. We believe it originated in probably Swale or Medway, and then rapidly seeded itself in South Essex and northeast London. And you could see from the data in terms of the hospitals, that hospital bed data, that I've just shown you how rapidly then that increased our community rates, and then the subsequent impact on our health and care system. In terms of what we could have done differently, I'm not sure very much in terms of the new variant. My sense actually was the thing that had the biggest impact was the closure of schools, because we could see the new variant was far more transmissible than the old variants in children and young people. The wild variant, we believe, isn't that transmissible. And what we could see in the epidemiology just before Christmas was that that's where we had huge. We had an overall rate in 11 to 19-year-olds of, I think, about 2,600, 100,000, and that really was driving the epidemic locally. I don't believe that this difference in tier status between Essex County Council and Thurrock and Southend in mid-October would have made any difference at all. In fact, if you look at our epidemic curves and compare them to Basildon and Brentwood, what you find is they matched almost perfectly. So I don't think there's any evidence that the change in tier status in October in Basildon and Brentwood compared to Thurrock had any material difference on the epidemic curves, and there's quite risk levels that it didn't.
Do you think if we had gone into a full lockdown earlier, though, that could have made? I mean, obviously that's not a decision that we can take at a local level, but
you're asking me to have a crystal ball looking backwards. I mean, who knows? I think
but certainly the tier systems didn't really have that much impact.
I think that there's some evidence that the higher tier 3 maybe had an impact on the wild variant. I think with the new variant, it was very clear that tier 3 wasn't going to hold the new variant anywhere. So the differentiation of the tier status between different areas in terms of new variant, I think, was a little immaterial.
Thank you.
I think I've said this before, although Ian doesn't feel like he has a crystal ball. In our last proper meeting where we actually did meet for real, he did say he didn't think local lockdowns would work because it was just too micro controlled, and you just had too many leakage. And I think that's what sort of happened with the tier 2 situation, where there's still too much freedom going around. But I mean, this variant did catch us off. I do say that I did ask for more action to be taken on the schools sooner, and it was not really taken up with by the council. They didn't wish to support shutting the schools sooner. I know we had to take the lead from Education Secretary, but I just do wish that we could have shut a week earlier to see if it reduced that infection. I know locally in my area we had a lot of the schools were shutting and classes being shut. Okay, Ian?
I think it's worth saying that the council doesn't have the power, and never had the power to close schools. Schools are independent. They're largely academy trusts. So that was a decision for the Secretary of State and the academy, not the local authority.
Okay, I think that's what Roger was just about to answer as well. I was aware of that, but it was just something that we could see coming, and the numbers were going up, and the teachers were emailing saying we've got no staff left, and so I'm just going to bring in Mark. Sorry, Mark.
The conversation has moved on slightly, but I just wanted to come back on Councillor Redsell's concerns around care homes, and just to provide a little bit of assurance, really. So before we go into the care homes and do any vaccinations, we do a kind of like a thorough risk assessment, and we've been really very, very well supported by our kind of public health colleagues. Have been invaluable in terms of kind of providing that kind of advice and information. But before the kind of teams go in, that there is a thorough risk assessment. If it's clinically safe for the teams to go in, then they will do, and they are doing. Indeed, I think our chair's on the call, and I think he was vaccinating the care homes this very day. We're making really good progress in terms of those kind of vaccinations and the rollout. There is a target that we will complete all of the care homes and the care home staff by the 24th. So we're working really, really hard to that deadline. So just a bit of assurance really that, you know, where it's clinically safe to go in, we're doing so. We're being really well supported by public health colleagues in terms of the kind of intelligence and advice on when that's safe to do so. It's ultimately a clinical decision around whether they think they can do it safely, and we are making really, really good progress. And within that prioritisation, the care home staff is the top priority within the prioritisation, if you like.
Councillor Holloway.
Thank you, Chair. A couple of questions. The first is, do you think, Ian and others, that we should be adapting our advice to residents, bearing in mind our new variant? So, of course, always it's been, you know, wear a mask and keep your distance and make sure you're kind of cleaning your hands. But does that guidance need to be updated? You know, should we be telling people to wear a mask pretty much as soon as you step out the door? Should we say be giving more space? You know, are there differences with advice, or, you know, that we should be telling people based on this new variant? And my other question is, with regards to the working age testing for those who obviously aren't working from home, because they'll be often testing if they're symptomless, does that mean we should be telling people to repeatedly be tested? Because of course that means, you know, they can obviously if they've got negative one day, that doesn't mean they won't be positive the next. And how are we advising people, and does it skew our figures? Thanks.
Right, okay. In terms of the advice with the new variant and whether the advice needs to change, the answer at the moment is no. I know Public Health England, that's why I'm saying slightly hesitant, because I know Public Health England are looking at this in great detail at the moment, and a technical briefing is promised imminently and has not yet been released. So unless that says something wildly different, certainly the advice at the moment is no. The current guidance will hold the new variant, but compliance becomes much more important. So this new variant is much less forgiving if anyone breaks any of the guidance for even a little bit of the time, which again, I don't say that to criticize people, because it's really tough to stick to every single detail of every element of the guidance at all time. I don't think there's any evidence that wearing masks outside will make any difference at all, or is required. And I know Jonathan Van Tam this morning was saying something quite similar. But at the moment, the answer is no. But if we could get everyone to just be absolutely rigorous in washing their hands really regularly, not touching their face, making sure that you absolutely are 2 meters apart from everybody else at all times, then I think that would go a long way. Sorry, in terms of your second question, which is the frequency of needing to test, unfortunately, testing capacity isn't infinite. I would love to have enough PCR testing capacity to be able to test everyone every single day. But yeah, in terms of the amount of testing capacity we have in the labs, that's not possible to do. The current program that we have launched is encouraging people to get a test if you're a working age adult. I don't know how long we will be able to maintain our PCR testing capacity at the level we've got at the moment. What central government, I think, understandably does is prioritise that part of that capacity at the areas of the highest rates. So you kind of become a victim of your own success as our rates start to drop. We may not have all of the capacity that we have at the moment. There is the option to implement lateral flow community testing, which we're certainly looking at very closely, and we'll be ready to roll that out should we lose some of the PCR testing capacity in the context of testing the community, although it's not as accurate, so you won't find as many positives as the PCR. It's better than not having any testing capacity at all. So we need to have that in our back pockets for if and when the PCR testing capacity is reduced.
Thank you, Ian. Councillor Muldowney.
Thank you, Chair. I mean, Councillor Holloway's partly asked the question that I wanted to ask about asymptomatic testing, because there is quite a high rate of false negatives that can come with that, as I understand it. And I do know, talking to a few people that have contacted me, sort of who are healthcare workers, there didn't seem to be, even within that group, that much of an understanding of why they were being asked to test twice a week, why they had to keep doing that, and also when they had COVID, why they then didn't have to test for 90 days. So I'm just wondering around the communication on that. The other thing that I wanted to ask about, are we, so this I can understand doing the PCR testing to get sort of like a snapshot of data, which informs then measures going forward. So is that what we're aiming for with testing working age people?
I think where you've got a very high background incidence, which I think from the data, it's reasonable to assume that we have, about a third of that population will have COVID-19 asymptomatically. And so being able to detect those and isolate them shuts down onward transmission. So even doing that once, where you've got a high level, you can capture a large number of those people and isolate them so that you break all of those transmission trains, that should have a positive impact on overall prevalence. So I think it's greater than just surveillance. Ideally, as I say, if I had enough testing capacity, I'd want to do this, every day for every person in Thurrock, but that's, in the real world is not going to be possible. So we will continue to do this with PCRs for as long as we still have that functionality and that capacity available. Should that be withdrawn, or when it is withdrawn, if we get spikes in other areas of the country, I think there's a reasonable chance that resource may be diverted. Then we have the option of testing with lateral flow tests, which we could arguably do for the community on a much more regular basis. The disadvantage is that they're not as accurate as the PCR. So, as you rightly say, you will get some false negatives and you'll miss some people. But I think you could argue that it's better to pick up some people who wouldn't otherwise be tested at all than no one.
Yeah, I understand that. That actually leads me on to quite nicely to my last question, which is about test, trace and isolate, because obviously there's been a lot, we're hearing a lot about vaccinations, which are obviously incredibly important, but what is happening with test, trace and isolate? Because surely we still need a functioning test, trace and isolate system, even as people are being vaccinated, to try and isolate cases and stop the transmission of the virus through proper quarantine and isolation measures.
Sure.
Is it working on the national level? I mean, I know we were doing quite well on the local level, but what's happening on the national level? It seems to have gone quiet.
I mean, it's certainly still functioning. As you know, that there's two elements to test and trace, and the test and trace program. There's the national. There's the national functionality, and then we've built our local contact tracing cell to try and find what are usually the more complex cases, whether that's advice to high risk settings, or actually quite a large portion that the national program is missing because it doesn't have the local intelligence and the data that we have locally. So both of those are still operating. The Thurrock, I think it's fair to say they're both incredibly stretched at the moment. If you think, at the start of December, we were getting 40 or 50 positives a day. We are now sometimes getting 5 times that. And for each positive case, you get on average 4 contacts. So we are constantly chasing to catch up with capacity. We've been out to advert, I think, 3 times and recruited more and more contact tracers. So the entire team is probably about 5 times the size it was in September when it was launched. So I think they're coping well. Their performance last time I looked was over 90%, which was considerably more than the national scheme. We use our local data and our local intelligence, that local knowledge. We have to ring up a GP and say, you know, we've got half a name here or half a phone number, and we're not sure. Whilst the national team wouldn't know who to call. So I think that local knowledge is really helpful in improving the performance, but it's not without its challenges at the current level of infections that we're seeing.
Thank you, Ian.
Ian, I just want to ask a question about the app. So I do understand there's a level of self-responsibility when it comes to the app, that when you receive your result, you input your test result into it yourself, and that then sends out notifications to everyone you may be in contact with. Just at the beginning of the week, my wife got one where she said she had to isolate for one more day, and that was the first time she'd been told. And today she got one that said she got isolate for 6 more days. It just seems very hit and miss. How's the app actually working, or does it work?
I mean, I'm probably the wrong person to ask detailed questions about the app. This is something that was obviously developed centrally rather than locally. It works, as you say, by holding the information in the person who tests positive's phone, and then they have the option about whether to share that information. And my understanding is that it then looks back when they give permission to share the information about who's been in close proximity using, I think it's Bluetooth, and then pings those notifications to the phone. So why your wife was told to self-isolate for one day, I obviously don't know, because I can't see that data. I suspect it is probably because the person who tested positive didn't give permission until the very last minute, and so that's when that was pinged, and that's when your wife received the notification. But it's obviously not something that we've developed locally.
I mean, I do have residents that live above the shops in Corringham that, because they have their track and trace app on, they don't go out the house, but they're always being told to isolate because people walk past underneath, notifications come through from them. So there is quite a big flaw within it. We still recommend it for use.
I mean, it's not something that we've developed, so I would recommend everyone uses it just as a concerned citizen, because I think if we all use it, it's better than not having it. But I can't. Yeah, the recommendations from central government, they have developed it, and I could see no reason not to recommend it, or to recommend not to use it.
Okay, thank you, Ian. Okay, now can I ask Mark Tibbs, Anthony McKeever, and Roger Harris to provide the members with an update, please? Over to you.
I think I'll
Mark's
go
going first.
Max sends his apologies. He wanted to just say that he's obviously still in the middle of managing the kind of current crisis as kind of Gold Commander, so he wasn't able to join us today, but he did extend his thanks to all of the kind of colleagues in Thurrock who've been working so hard. So I'll begin and provide a kind of like a broad overview of the kind of system response to the pandemic. Obviously, the system has been under kind of unprecedented pressure. We announced the critical incidents between the kind of Christmas and New Year period, and that was a reflection of the kind of volume of patients we were seeing in our hospitals, and the pressure that those hospitals were under. Ian's slide kind of described that sort of graphically very well. So the numbers of patients on ventilations and the huge numbers of people within the hospital requiring oxygen. What those numbers didn't show was that there are also a number of patients that went outside of the Mid and South Essex area. So there was a lot of mutual aid, particularly the Papworth in Cambridge, where a number of our patients were transferred as our capacity for ICU beds ran out. So that kind of mutual aid across the region was very, what is and was very prevalent through the crisis. The number of patients with COVID in the hospitals has been rising very steadily. As of the kind of latest data I've got in front of me, across the 3 hospitals, there are about 850 COVID patients, about 355 of those being in Basildon. So, and that represents close to half of the hospital capacity being with COVID patients. So, an enormous impact of the disease on the hospital. I think probably people will have seen in the press over the weekend the kind of impact on the physical infrastructure and the kind of flow of oxygen as reported in various kind of media outlets, and that was reflective just of the kind of unprecedented level of respiratory and COVID issues that were in the hospital. In addition, the kind of length of stay in the hospital has been exceeded with those patients. As we've got better at treating, as the outcomes of the treatment get better, then people are often in the hospital for longer, which is obviously great news clinically, but compounds the kind of bed pressure that's kind of felt in the system. The kind of response to the kind of crisis has been very extensive. We have opened up a large number of community beds, additional community beds, with various kind of levels of acuity. So the Brentwood Community Hospital site has been really kind of focused on that kind of subacute level. We have had support from the Army to enable us to kind of open up that red capacity. That kind of support is quite short term in nature, but obviously very welcome. We have opened up additional beds over in Braintree. Additional beds been opened at the Mayfield unit, and indeed we have opened up Meadowview at Thurrock Community Hospital as a kind of designated red site. So there has been enormous efforts to absolutely maximise the capacity, the community capacity, and both the kind of red and green pathways, so that we can maintain that kind of flow out of the hospital. I'm sure Roger will pick up that same issue from a kind of a residential care and domiciliary care perspective. The impact of the disease has obviously been across all parts of the system. So our community services have been hit as hard as our hospital services, and the kind of the manning of the additional kind of hospital-based, inpatient-based services. We're working with the kind of limited workforce, and that has required us to kind of prioritise and focus on the COVID response. So that for our kind of NELF colleagues, for our community colleagues, that's meant ensuring that the RAS service is prioritised, and that there is a kind of robust kind of community respiratory discharge pathway, including a kind of virtual ward model whereby we are working very closely with our consultant colleagues to ensure that the right respiratory support and expertise is available in the community. We have done a lot of work supporting the care homes, making sure that the GPs are providing kind of robust response and support to our care homes, making sure that each of the care homes has a Whiz-An device which enables the care home to take kind of basic kind of metrics, kind of blood pressure and temperature, etc., in their home, and that can be fed into the GP system. So that kind of dialogue and support between the care homes and the GPs has been enhanced as part of the response to COVID. As you'd expect, the call volumes into services like 111 have been extremely high. So there probably have been some dip off in terms of response times to kind of answering the phone, but just absolutely reflective of the kind of the volumes of calls that have been taken, and obviously the workforce impact as people have been off sick. But the service has maintained a good service. Similarly, from a kind of mental health perspective, the mental health services have seen kind of greater acuity of patients within their wards. So a kind of bit of a sense that during the first wave of the pandemic, the mental health services were able to discharge a lot of patients, kind of empty the wards and kind of maintain sort of social distances and lower occupancy levels of the wards as they were able to kind of discharge more people into community services. The sense from this wave is that that's been much less possible as the kind of acuity of patients in the wards has been that much higher. Similar to community services, the mental health services have prioritised the kind of crisis aspects of their pathways. The services are, open and taking referrals. Waiting time for services like IAPT remain quite low. So I think it's important those messages kind of get out that the mental health offer is still there and people should be accessing it. From a primary care perspective, primary care is also going through the same process of prioritisation and making sure that the primary care effort is supporting those discharges from hospital, stopping admissions happening in the first place through things like the care home support and obviously the huge vaccination programme. I will touch on the vaccination programme in my, shall I touch on the vaccination update now? Yeah. So obviously a big part of the primary care response, or an increasing part of the primary care response, has been the mobilisation of the vaccination programme. The national plan was published on Tuesday. There was further guidance on care homes yesterday. So it's a kind of a reflection of the kind of fast pace of change and the kind of quick response that our kind of clinical colleagues are having to make to the kind of responding and changing needs of the pandemic, but also the kind of guidance around how to manage it. So people will be aware of the kind of vaccination prioritisation, the four groups. So kind of starting with residents in care homes for older adults and the staff working in those care homes, the over 80s and frontline staff, and then moving into the 75s and the over 70s. So the kind of prioritisation has been nationally set. We have, as I mentioned before, a target of completing all the vaccinations for the care homes and their staff by the 24th of January. We've made a really, really good start with that. Including today, including a number of care homes that were done today. So we believe that we are on track to be able to deliver against that target. The four priority groups we are expected to complete by the middle of February. So for context, that means from probably where we are at the moment, delivering around 5,000 vaccines per week. So a tall order for a relatively small CCG, but that is what we are endeavouring to do. I guess as the supply of vaccines arrive, we vaccinate people. So the kind of vaccines don't don't hang around, as you can imagine. As soon as they arrive, they go. Logistically, there's some challenges that has been in the media. So the kind of Pfizer vaccine arrives in large trays of kind of nearly 1,000 vaccines. So they need to be delivered from sites that are able to kind of mobilize kind of quite high volumes. The AZ vaccine kind of arrives in smaller trays, and we're now focusing that more on the kind of the care homes, as that's more easier to transport. Again, people will be aware that the kind of delivery model involves these kind of 3 tiers of sites. So we have kind of hospital-based delivery, we have mass vaccination sites, and then we have the PCN, primary care-based delivery. So locally, the Basildon Hospital site was up and running before Christmas and is ramping up the delivery, as we speak. As more supply comes, they're able to deliver greater numbers of vaccines each day. The kind of the 2 PCN sites within Thurrock, so we have one in Stifford Clays and one in Chadwell. They're both up and running and delivering vaccinations. The mass vaccination sites, there's a kind of couple of elements to that. There is the 7 national sites. So the 2 local ones for us are the Excel, and there's one in Stevenage. There's kind of 7 sort of national mass vaccination sites, but there are also a kind of mobilisation of local mass vaccination sites. So the first one of those for us will be in Runwell, with the plan that there will be one at Thurrock Community Hospital shortly afterwards. Obviously, it's a big pull on staffing resources. It's a massive team effort. The kind of PCN delivery is an extraordinary effort from the GPs, from nurses, from pharmacists, from paramedics. We're bringing in the social prescribers, the receptionists, the kind of ringing up of patients, the logging of information onto the system is, as you can imagine, a huge logistical effort. We're training as many people as we can to make sure that there's as much resilience in the system locally as we can. That includes a big effort from volunteers, both kind of St John's Ambulance from a kind of administrative perspective, but also we have had a huge response from our colleagues from Kim and Christina, helping us get volunteers for marshalling around the car parks and making sure that the signage all works and people know where they're going, which is absolutely enormously valuable. We have redeployed a lot of our CCG staff to support the same. So either vaccinations or kind of supporting on the logistics side. From a kind of data perspective, there is a promise that the national data will come out shortly. That will then start to be broken down into regional and system data. But at the moment, we don't believe that it's possible to kind of break that down by local authority. That may change in the future, but our at the moment, the kind of information gets submitted onto a national pinnacle system, and then it gets transferred back onto the GP system. So the kind of the control of and join up of information between the 3 sites is somewhat complicated and quite tightly controlled from a national perspective. So in summary, we are absolutely kind of delivering the vaccinations as soon as they arrive. We will have more and more sites available as the kind of mass vaccination sites come on board and support the kind of PCN and the hospital-based vaccinations. It's been an enormous effort on top of the management of the crisis and the pandemic itself, kind of having to mobilise such an enormous logistical effort whilst people are, quite exhausted and tired from actually managing the the uncertainties and the kind of and the practice to kind of manage the crisis has been an enormous effort. And I'd just like to be good to kind of note that kind of thanks to those frontline staff for working so hard to deliver both the pandemic response and the vaccination programme.
Yeah.
Thank you, Mark. Do you want to go straight over to Roger?
Thank you, Chair. So just to endorse that last point as well, I think the actual, I'm amazed at the resilience of staff. Most staff now have been working basically 7 days a week for the last few months since it all took off again in November, and that I'm just so enormously proud of my whole team. So I think that's worth recording from the social care side as well. I think we're rewriting the manual here in terms of managing sort of critical incidents, because I think just once we put in a contingency plan, we get overwhelmed, and then we have to put in another contingency plan. So as Catherine will know, we're considering another contingency plan tomorrow in case that the peak hasn't been reached yet. So just to give you a bit of I suppose, a flavour of some of the things that we've had to do over the last 3 months in particular, it's certainly since about mid-November onwards, it has got really, really difficult. So most of our care homes have been in outbreak at some time over the last 3 months. As soon as an outbreak occurs, there is a wraparound system that is put in place. We've got very good support from the GPs, as Mark has said, and there's now also a helpline from the consultant geriatrician on call, which again has been extremely valuable in terms of supporting the care homes. The biggest problem though has been around staffing. What has hit us so badly this time has been the number of staff that have actually been self-isolating or have actually been off sick themselves. So it was actually, we've had to redeploy staff across from both within adult social care and from other parts of the council. So day services have closed since the outbreak, and we've had to redeploy staff from day services. We've also had to redeploy staff from other areas, and we've had some support from some of our community voluntary sector providers, and particularly like to mention Thurrock Lifestyle Solutions, who have taken on some domiciliary care duties because some of their centres have been closed, and that's really helped us out in terms of domiciliary care. We established what was called a designated setting. So anyone who comes out from hospital who is COVID positive doesn't go straight back into a care home. They go into what's called a designated setting. And so we mobilised Oak House very quickly. And in fact, we were and still are helping out Essex County Council because they weren't able to get their designated setting up and running. So we were giving them a bit of mutual support. We've also paid a number of resilience payments out to our providers. So we paid 10% uplift for a period of 6 months, and we've now agreed a further 5% uplift for the periods of January, February and March, just to give some extra resilience to both our home care and our residential providers. But it is actually trying to maintain those safe levels of staffing that has been the particular challenge. So we have had to get in quite a significant amount of extra agency where we were able to, although it was difficult to recruit from agencies because I think everyone is trying to get staff from a similar pool. We've had 3 times a day incident management teams where we review all the patient flow, and again the hospital social work team have been absolutely brilliant. We took the decision early on to keep the hospital social work team in the hospital, and they have been working 7 days a week for some months now, and we're in all over Christmas as well. So I think now we are with the position where it's certainly the last few days has felt a little bit more manageable. The patient flow now, the numbers we talk a lot about the patient flow, but we were getting to the point where the numbers going into the hospital were vastly exceeding the numbers coming out of hospital, which is why, as Mark said, we had to increase the bedded capacity locally, and we have been looking at other contingencies as well. But we now, the numbers of people going into hospital, numbers are coming out of hospital has stabilised, and we are managing the patient flow much more, I think, better, and we're able now to keep those the delayed discharge from hospital are now very low for Thurrock, I'm pleased to say. We just, I think now just need to get more staff back to work. I think that is our absolute critical task. We have put on some 2 emergency training programs as well. So we made a call for action from volunteers, and again, thank Christina and Gage and the CVS because they identified a number of people who were able to volunteer. It's because it was actually personal care. We had lots of people volunteering to do duties and responsibilities, and that was absolutely fine and that was brilliant, but it was actually care staff was our biggest problem. So we actually managed to put on a crash training course to train some social workers who were redeployed, some volunteers and people from elsewhere in the council. We were able to put on this training program, and that has particularly helped us both in terms of maintaining the safe staffing levels in residential care and at Oak House, which is our designated setting. We've also had to do what's called a prioritisation exercise, and I think this is where it's been particularly difficult. So we have had to, like the NHS has had to do, prioritise those people most in need. So we have now, not everyone has had the review on time, so we've moved largely to a phone call for reviews, not in every case, but in a lot of cases. As I said, day services have been closed, but we need to make sure that we're contacting people who've been receiving day services. And again, that's largely been by a phone call. Our respite services have had to be scaled down as well. So Breakaway hasn't had the full level of beds that it has had previously. So we've had to scale that back as well. And also we've had to do what's called our red, amber, green exercise, where we do a RAG rating on people who possibly could manage with less calls but still be safely looked after in the community, because we've had to prioritise staff for those areas where people need more calls. So we're having to do that with our providers, and again, our providers have been very supportive in this. So in summary, Chair, it remains incredibly difficult. You know, we are, as I say, reviewing this at least 3 times a day. The number of calls you have, I think drivers are all completely mad, you know, from an 8 o'clock call, 12 o'clock call, 6 o'clock call, which I think most of us are all on, plus a number of operational meeting calls as well. But just to make sure that we don't miss anything, that we're providing support to both community health, the whole system as a whole. But I think now it feels that we are possibly, I'm very hesitant to say this, but possibly have reached the peak. And I'm encouraged now to see that the staff sickness levels are starting to go down, because over Christmas they were absolutely dire. Collins House at one point had about 60% of its staff either off, either self-isolating or sick. But I think we've come through that difficult period as well. So I think I'll stop there, Chair, and take any questions along with my colleagues.
Thank you, Roger, Mark. First of all, Roger, I just want, for scrutiny, just to clarify that we have not turned any residents from Thurrock away from Oak House. They've not been jeopardised at all.
Not at all. No. As I say, we've been able to help out Essex, who had difficulty in getting their designated setting off the ground. But equally, you know, we had a mute arrangement with other with Essex and Southend if we needed access to their beds as well. So we've been working as a system, but no one has been refused a bed at Oak House because we were full.
Thank you, Roger. Mark, just want to go back. Can you say, have we ever returned any trays of vaccines unused or turned down the offer of them?
No, we haven't returned any vaccines. The DNA rate is very low. The wastage rate is very low. So when the vaccines arrive, they are all used up. At the very early part, probably after the first tray was delivered, we were given sort of 12 hours notice to whether we wanted an additional tray, kind of like an unplanned tray. And we weren't able to mobilise the staff at that very, very short notice. So there was an occasion where we turned down a tray because we didn't have enough notice to be able to get all the staff. But no, there have been no wastage and very, very low DNA rates for all of the vaccines that we've received.
Thank you, Mark. The other thing that I know I asked this earlier in our meeting, but for scrutiny, we do see these press releases come out from the government that pharmacists and local GPs are now doing vaccinations. Can you clarify that no local GP in foreseeable future will be offering a vaccination at their surgery?
So I see Rahul's hand is up, so I might defer to my colleague.
So so apologies, I'm not turning on my video, otherwise my Wi-Fi fails me. It's very difficult to say no practices in the future will not be offering vaccinations, is because AstraZeneca vaccine is much more stable. I think the reason why the government wanted all vaccines to be delivered on a collaborative PCN site model was because of the complaints that the vaccines brought onto everybody. So Pfizer vaccines is very restricted to move from one place to the other, and it has to be administered within 3 days once it arrives, and it arrives in batches of 1,000. So I think for a single small practice, it's very difficult to do that. But with the arrival of the AstraZeneca vaccine, which is much more stable, can be transported, I think there is a intention for the future that these vaccines could be delivered through that is being floated around. So whether or not it becomes a reality, when would it become a reality? I don't think, none of us know about that.
Thank you, Rahul. Yeah, I think it comes sort of a bit of a myth because we've seen other areas where having it done. And it's like today, the pharmacy list has come out, and we had the discussion that it does require a certain size of unit to be able to do these at the pharmacist, but none were in Thurrock again. I do just feel, are we getting a substitute? Are we getting like the Stiffer Clay site to substitute not having these in the pharmacies and doctor surgeries?
Not to my knowledge, Councillor.
Okay. So is there a chance that other areas are getting more vaccines than us if they can do it in the pharmacies?
I'm not aware of any pharmacies that are offering the vaccinations across the Mid and South Essex Health and Care Partnership. In fact, there is a talk on plans being made around a rollout of the AstraZeneca vaccines or being administered through pharmacies, but it hasn't materialized to my knowledge. In terms of are other places getting more vaccines than us, I don't think so. I think it's now almost like based on the readiness of the site. So as Mark said, is in the initial rollout phase, I think there was an option to get 1 tray of Pfizer vaccine, which the PCN declined due to lack of staffing. As we said, it was a very last minute planning to say, we've got 1 spare, do you want it? And the PCNs didn't have enough workforce to deliver it. But what we've done is this week we've taken extra tray within Stifford. So I think it just makes it up. And in terms of the delivery, it's all nationally determined. So centrally, it's determined which site will get what amount of vaccines.
I see today that we have the help of the army now with the vaccines. Is that correct?
Mark, did you wanted to go on that one? Because I don't think we're getting the army to vaccinate, but there is army to support the community hospital.
Yeah, I suppose just on your previous point, Chair, there's a national target that all of the kind of 4 priority groups will be done by the middle of February. So we're expecting to have enough supply to be able to hit that target in this area, and the kind of modelling of in terms of the national distribution of the vaccine is based on all areas being able to do that by that point. So I don't think there's a sense that we are getting less vaccines in other areas, or we have less capacity to kind of to deliver it. I think that ambition is the same right across the country, and we're all working incredibly hard to be able to deliver that. I saw in the press as well the offer of the army to support the vaccination. It's not something that's kind of filtered down locally. That they are supporting, as I said, at Brentwood Community Hospital in terms of the step down subacute capacity, but I've not heard of any involvement in vaccinations.
Thank you, Mark. Obviously, what I'd be concerned about is obviously without having the stats, the data, the numbers of vaccinations we're giving, we can't scrutinise the process of how the situation's going, if we're going to hit the target, if we're not going to hit the target, and comparing that to other areas. So it'll only be after the 15th of February we'll know if we've hit it, if we can't track the numbers going up to that. Okay, Councillor Holloway. Rahul, do you want to come in on that?
Yeah, I mean, as Mark said, we've been given a target to vaccinate 5,300 vaccinations every week, and if we hit the target by the 15th of Feb, I think the national target, which is about getting 20% of your population vaccinated, I think that will be met. So we'll know that we've hit 20% of our population target.
Thank you, Rahul. Councillor Holloway.
Thank you, Chair. Yes, my question is two questions, actually. There was a mention of the concern in the press with regards to oxygen level and supply going to some of our hospitals. I know that this was a few days ago now, and it was something to do with, I think, Southend Hospital rather than Basildon. But with regards to kind of our supply of oxygen, are we confident that we will always are going to have enough oxygen that it's that we need, and that patients won't be withdrawn if they don't need to be withdrawn, and can we really reassure people that we are going to have those levels, and people don't have to worry? And my second question is with regards to the vaccination process. I know that a lot of this is sorted nationally and the numbers are kept nationally. I'm just a bit concerned about how we know how well we're doing. So that by the 24th of January, it's care homes and staff. So how many? What's the numbers? How many care home, people in care homes and staff are there, and where are we? At what stage are we at? And similarly with our 4 priority groups, that the deadline is for the 15th of February. How many people is that, and where are we with vaccinating them? How is it possible that we're not? Could it be possible that we're not aware of what numbers we're getting? How do we order enough vaccines if we don't know how many are in each of the priority groups? So I'd appreciate having a breakdown on that. And then just to add, as we always do at meetings, what you said, Mark, about a huge thanks to staff. I know you've all been working incredibly hard. I know we do say it every meeting. I don't know how best we can just say how grateful we are. We know how hard you're working. If there is anything we can do as elected members, I know that we've, as councillors, we are trying to help in our communities. We're volunteering and delivering shopping. I've taken part in a COVID vaccine trial, so I've had lots of blood taken over the last few months. But if there is anything else that we could possibly do that you can ask us to do, please ask us if it will help. We obviously suggested I suggested at council last year about an awards event, which obviously we can't sort out till all of this is kind of we're kind of back to normal, if there will ever be a back to normal. But we'll be able to show our appreciation then. But please, if there is anything we can do, please get in touch with us.
Thank you. Shall I answer the points you raised? I think that kind of that award idea is really nice. Actually, it's kind of I think how we express that gratitude is really important, and also kind of how we support staff's well-being when this is over. I think that there's going to be people that are kind of quite traumatized, particularly intensive care staff. So how we get really good psychological support for those individuals, kind of occupational health, and I think that will need to be a real whole system response. So yeah, I think it's gratitude, and also the support and the specialist support that we kind of provide to those staff that have kind of been through some really difficult things over quite a long period of time, actually. In relation to the oxygen, I think, so I'm not an engineer, as you can tell, but my understanding is that the issue at Southend was around the kind of flow of oxygen rather than the supply of oxygen. So it was around how the oxygen was kind of flowing around the hospital. So I'm not aware that kind of there are supply issues around hospital. It was the kind of the strain on the kind of infrastructure. Obviously, and again, I think this was reported in the press, you know, the system is getting, you know, all the expert advice there is available, linking in with the kind of region, national kind of colleagues to kind of to make sure that it's, you know, that it's good to go. So, but it wasn't a supply issue. I think supply is good. And the work on the kind of infrastructure and getting the engineer support, etc., is all happening as we speak. So I think we can be assured on that. In relation to the numbers, I think the issue is that the Thurrock population will be vaccinated from 3 different sites, and all of those sites will put the information onto a national system, and that national system will then publish the data, and I think that data will become published at increasing granularity. So so it's not, so I understand your frustrations. The national guidance and the national plan talks about working with public health colleagues around intelligence, etc. But when the data is kind of is held and controlled quite tightly, that's kind of quite difficult, I would say. So I hear what you're saying. I don't have the solution to it, if I'm honest. It's the numbers are quite closely controlled, and I think that there's a kind of I don't know whether there's some sort of national fears around different numbers, unvalidated numbers kind of like being sort of spread around, and kind of there being kind of competition between different areas, etc., and the like. So that kind of the comms and the kind of flow of data is beyond our kind of local control.
Councillor Holloway, do you want to come back on that?
Oh, yes, please. Thank you, Chair. I'm just thinking about, I understand, I know these logistically are huge logistical issues. My concern is with anything that seems to be organised centrally, it never seems to go very well. Anything that the government, or anything that touched by the government, track and trace, or anything kind of nationally done, doesn't seem to work all that well. So I'm not filled with masses of confidence. But how does it work on a really practical level? I can't really get my head around how if you don't know how many are in the 4 groups, or how many are in care homes, can you then issue the right amount of vaccines to ensure that we have enough, or that things aren't spoiled? So how do the national government know our numbers, or are they just relying on just sending a few vaccines and then updating the system, and then I don't know, is it guesswork? How is this done on a practical level to get done properly?
Mark, I think Anil was trying to come in on that one.
Yes, thank you, Chair. I was just going to say it is a bit complex, isn't it, and complicated. But when you have four systems providing vaccination to the patients, I'll just bring down to our surgery local level. What we do is we run a search on patients who are about 80. We call all those patients about 80 and invite them for vaccination. But like Marcus said before, the delivery of vaccination tend to be a problem. So we may be told that you have 2 trays coming in the next 5 days. So the logistic behind that, calling all those patients in that period and getting them to come to the vaccination center can be difficult. But there is a pathway. With each surgery, tend to run a search on patients about 80, about 75, and start calling them and come for the vaccination. So I think we will definitely have data on that. I'm sure Rahul has raised his hand. He's got numbers with him, I think. So he might be able to give the numbers.
So thank you, Chair. Yeah. So we do roughly know how many over 80s do we have in Thurrock who are ambulant, how many older, how many residents are in our care homes. So we have those numbers in that case, and so do centrally they have those numbers. I think within Thurrock we've got about 6,000 people over 80s who are ambulant, and then we've got about 700 people who are admitted within our care homes. So we're working on those levels, but again, as we said, as Mark said, the data and the statistics are quite tightly controlled, and the issue about keeping a tab on it is also difficult, because where, like a flu jab, GPs would record in system 1, so you can just run a search and you can pull out the data. But this time round, we've been stopped from entering into system 1, but we have to enter into a national database, which is Pinnacle. And this tends to be quite clunky most of the times. When you are nationally, everybody is trying to upload thousands of data within it. Once it goes into Pinnacle, I think the ultimate aim is it's going to go into the GP system, which is system 1 and EMIS. But the lag between uploading data onto Pinnacle and Pinnacle then loading into system 1 is so great that even the patients who were vaccinated in week 1, which was in, I think, 14th or 15th of December, it's still not filtered down into the GP system. So I know it's a bit clunky, but that's the best response we have around the numbers and the data.
Yeah, that's really helpful. Thank you, Chair. I mean, it is. I understand. Obviously, I realise locally we have the numbers. I just think the system does appear clunky. I am concerned. I'm not massively reassured. I know that this is nothing we can do at a local level, and I think it's probably strange why we haven't brought it up. But as Councillor Ralph said, it's probably, as he brought up, one area doing better than the other. I think the competition element would probably be a factor in it and cause more drama. That said, I'm still not reassured, but I'm glad that that things are moving forward, even if I'm not reassured.
Thank you, Councillor Redson.
Thank you, Chair. Just like to echo Councillor Holloway. I'm not sure whether awards are the right thing, and I shouldn't think people actually want an award for doing something. But just picking up on something Mark said, it might be something we could do for all the people, perhaps, somewhere for them to go, tranquil, after this is all gone, if it ever will go. I think there's something there. I don't honestly think sometimes thanks is enough. It doesn't seem enough, does it? A thank you, to everybody. And we know everybody is working, as Councillor Holloway said, we are doing in our own wards, we are trying to keep an eye on older people and making sure they've got enough stuff if they need anything. So, and as Councillor always said, if you need us, just ask. We're all here to try and help. Just to pick up on something Mark said, with the giving the vaccinations, why aren't you picked up on Stifford Clays and Chadwell? Why aren't we using somewhere like Impulse Leisure, which has a great big place we can use to give injections in, which is more middle of the borough than it is to one end and another end, which are quite far away from each other? we've got a big building there and a hall that is not being used at all, where people can actually distance themselves from other people. So I just wondered if we've looked at that at all.
I think Rahul has the answer on that one.
Pardon?
Rahul, do you want to come in on that one?
Yeah, I'll attempt. I'm not sure if the response might satisfy Councillor, but I think the lead time given to the PCNs to put up sites was at record pace. So they were given literally a few days notice to put up the sites, and the logistics of even making those already health sites to make them COVID safe or the vaccination fit for ready was so hard that if you went for a non-health site, I think furnishing that and making it fit for vaccination would have taken even longer. And then you've got to get the CQC to come in and tick off. I think the regulations and all the restrictions that were there before a site could be ticked off to deliver was quite a lot. Hence we went for sites like Chadwell and Stifford Clays, because the Stifford Clays Health Centre bit where we're going to be delivering is almost quite separate from the main centre, so that with all these 400 people, footfall of so many people, hundreds of people every day, shouldn't disrupt the work of shouldn't disrupt the usual Stifford Clays Medical Centre. And same thing with Chadwell. Chadwell is very standalone medical site, and patients from Chadwell could definitely be seen into into the Dilip Sapnis, which is only across the road. So I think it was kept in mind that we did not want to disrupt the core business of general practice. Otherwise, displacing of patients would have really resulted in another pressure on other areas.
Yeah,
hence those two.
I can understand that. Thank you for that. The only reason I asked that was because Stifford Clays is very hard to park.
I know.
And so is Chedwell. You're giving people a bit of a logistic, if they've got to ride to it, everybody can't walk to it, can they? So most of those people are quite elderly and probably, some of them have got underlying things wrong with them. So it's finding it hard. Just those two sites are not very logistic in parking. That was the only reason I asked that,
Yeah.
Thank you for that.
Just before we move on, just aware of the time, and I know we've got a big debate coming up soon regarding the fees and charges. So if we can keep the next questions pretty brief, if you should go to Mark with an answer, please.
Yeah, I suppose it was just a few reflections really that actually the vaccines have only been approved for a very, very short period of time, and actually what's been mobilised has been mobilised really, really quickly. And I think probably what we're not fully through that mobilisation. We've only really just begun, and I think probably what we've got, what we've got is kind of two sites within the PCNs within Thurrock. People being invited into Basildon Hospital. We've got two national centres, Excel and Stevenage. So, and then we'll have two local mass vaccination sites, one of which will be in Thurrock. So, I think we probably need to recognise that we are only halfway through our mobilisation, and that we have mobilised an enormous amount very quickly. And I think we'll end up with a range of choices where people can go, which hopefully will provide for everybody's needs.
Okay, Councillor Muldowney, then Councillor Massey.
Thank you, Chair. I mean, I think actually probably Councillor Holloway has covered it with the vaccination questions that I had, although I did miss part of what Mark was saying because my connection dropped out. But I think it's been covered again since then. So I won't worry about that. But I just wanted to echo what other members have said about the incredible effort that there's been through all frontline staff, particularly critical care staff, but obviously all the management structure as well, right up to the Gold Commanders, and all of the council staff and our frontline staff. Across the whole board, it's just been phenomenal. I think sort of this week, as we've been able to see for ourselves, as the cameras have been actually let into hospitals, the true extent of the crisis that we're in at the moment. I've been very moved by what critical care staff have been saying, and just the incredible pressure that people are under. So I just wanted to add my thanks to everybody who's been working together. There was quite a nice thing that a consultant, intensive care consultant, said this week that I was reading, that the NHS is not an army, but it's a coalition of willing tribes who are coming together to save lives and deliver this massive effort to vaccinate the population, and hopefully get to a place where we can all go back to normal. So thank you very much.
Thank you, Councillor. Very nice. Thank you. Councillor Massey.
Thank you, Chair. Again, thank you everyone that's on this call, all of your teams, all your colleagues. We are eternally grateful for this mammoth effort, especially around the vaccine, which I can't imagine the logistics involved. My question is, I know we're partway through mobilising vaccination sort of rollout, and I know there's probably going to be more sites come online and things like that as we go on. I'm aware we've got lots of residents in Thurrock that live in quite isolated style lives or in quite rural areas. I did read on some literature regarding the vaccination. There's going to be some home visits, and I don't expect these to have been obviously from day one. I just wondered if we had any sort of timescale when home visits for those who can't get to a surgery might start being something that's arranged.
Does anyone want to take that one up? Rahul.
I will attempt to answer that one as well. So I think with the which patients to vaccinate is almost like a national diktat. So we were told, as Mark said, about the ambulant over 80s and the care home staff and care home residents and the frontline staff. Now with the and that was mainly because of the restrictions from Pfizer vaccine. Now that we've now got the AstraZeneca vaccine, which can be safely transported, I think this is something I would expect to come next on. So this will be quite imminent. What we're trying to do is within the local patch, trying to work with our PCNs and our community providers to see how we can safely, whenever we get the green light to start vaccinating them, is to start rolling out plans and start vaccinating our housebound patients. But what we've also started to do is our PCNs have started to do is, if they are aware of housebound patients living with somebody who can drive them, I think we're saying, if you've got somebody who can drive you, please bring them in, so that we're not limiting ourselves to say, look, if you can't get yourself there, we cannot vaccinate you. As long as you're over 80s and housebound, but can be brought in by a carer or by, I think the PCNs have decided to continue vaccinating those patients.
Thank you, Rahul. Okay, I just want to echo everyone's words of praise that's gone on. And when we talk about how we can reward the NHS staff, I think that's sleep. I think they're all going to need a really good sleep. Everyone who works in health. I know all of you have worked all over your Christmas to try and do this. I know I was speaking to you all just before Christmas Eve. It's hats off to you all and to everyone you work with in hospital. We really appreciate the fight that you're doing for us all. Okay, thank you. Just moving on now to item 7, proposed charges for 2021-2022 for adult social care non-residential. Report can be found on page 23 to 30 on the agenda. Can I ask Catherine Wilson to introduce the report, please?
I'm going to kick it off, Chair, and then Catherine is going to cover some of the consultation. So members will recall this has come here twice before. This is the just to remind members what I said earlier. This is the only discretionary charge that is where there is any increase proposed for next financial year 21-22. And this is by far and away the biggest in terms of impact, in terms of finances, in terms of income into adult social care. So you will be aware that we currently charge £13 an hour It is means tested. This current charge. The numbers do change fairly regularly in terms of the people that are in domiciliary care, but roughly around 1,250 people at any one time are in residential care, and of that, only 265 are full payers. So around about 20%, less than 20% are full payers. A number of years ago, it was agreed to peg the amounts that we charge to £13, even though the amount that we pay our providers has been going up over the years and now stands at £17.06 and may well go up next year as we're in the middle of the budget setting process. We went out to consultation to get people's views. We wrote to Catherine, will cover this in a bit more detail in a second, about possibly a phased increase or a full increase or no increase at all. The conclusion, I think, was, as Catherine will cover in a second, I'm mostly stealing all your thunder, Catherine, here. I'm just very conscious I'm not going to take everything away from what you might want to say. That we're also very conscious of the fact that the council is in a very difficult financial position at the moment, and although we clearly there's quite a lot of budget discussions still to be had before the council sets the council tax and the budget at the end of February, we are having to look at possible ways to maintain the current level of service, which has least impact on people that receive the service. And I will come back to the conclusion at the end. But before I steal any more of Catherine's thunder, I'm going to hand over to Catherine just to talk about the consultation process.
Thank you. So as you're aware, we went out to consult on the options that Roger's just described. The consultation process was 8 weeks, from the 12th of October to the 7th of December, and this is all detailed in the report, but I'll just highlight for you what we did. So we devised a questionnaire which was very simple, really asking 3 questions. Should we continue with the charge of a maximum £13? Should we go to a full charge of £17.06, or should we look to incrementally increase the charge, giving some options about what those increments might be? And as Roger said, it does not affect everybody who receives the service. It's just under 20% of people who receive the service that would be financially assessed to pay, or would have said they didn't want a financial assessment and therefore would be charged the full amount. The questionnaire was sent to everyone on that day who's receiving domiciliary care, and as we said, it does fluctuate even slightly, but it is round about 1,250, and on that day it was 1,248 questionnaires that were sent out. We also put it on to our consultation portal, the same questions. Both the questionnaires and the portal had the facility for people to make comment and to ask for a call back, because we were very mindful that we weren't able to undertake a face-to-face consultation with individuals. And in the past, we've always done that. We've always given opportunity right across the borough in every ward for people to come and speak with officers about proposals, but unfortunately we couldn't do that this time due to the COVID restrictions. So we had 172 completed questionnaires out of the 1,248 that were sent out. We also had 21 individuals who accessed the consultation and portal, and 17 completed the questionnaire. 153 people chose to leave comments, and some of the comments were incredibly moving about the gratefulness of people for their carers, the fact that they felt that carers should receive a higher salary than they do, and how much they valued the carers who went in to support them in their own homes. A couple of the other comments, when we kind of gathered them together, really the theme was that people felt there shouldn't be an increase because they'd previously paid their taxes and felt that it wasn't appropriate to increase. And also there were some comments left saying that they felt the decision had already been made and there was no point in completing the questionnaire. 4 people requested callbacks, and so my customer finance manager and one of my commissioners in my team rang them back and spoke with them, And in the main, those 4 people were just concerned about their service, and we were actually able to sort out individual difficulties for them, which they were very grateful for, but they didn't really have a comment to make upon the consultation. And I think that they are really the facts and figures of what happened. It was quite a low response, as you can see, but actually last time we went out to consult, when we were out in the borough as well doing face-to-face consultations, we didn't have anywhere near 172 people who actually responded. So it was we felt it was a really good response. So the outcome of the consultation was that 41% of people said that they would be prepared to pay an increase, and the rest said they didn't feel that they wanted to. So I'm going to hand back to Roger now.
I most probably at this point take questions, Chair, and then sum up at the end.
Okay, Councillor Edsel was in first.
I think I just beat Victoria then on that one. We never get a good response, do we, Catherine, on anything we send out? It doesn't matter what it is. Is it something telling us that most of these people probably don't do computers? And as you say, some of them are on the telephone. I just think that is really low, isn't it, out of 1,000 something? You know, what does that tell us about the rest of the people? Because we will never know their views at all. And I think most people will look at it as they get the best of care, and they would like to see more people. It's only, at the end of the day, it's going to be everybody's tax money anyway. Whatever we do, you know, it's going to come out of taxpayers' money. Whatever we do in the borough, I just I don't know what else you can do, actually, Catherine, to get people to write in and answer you. Really, I don't know what we do anywhere for a consultation. You know, we don't get anything back. Whether people are fed up with consultations and just don't want to do it anymore, because we have it on housing, don't we? Mm. You know, we try and get out there with housing. We still don't get that response back. You know, I think it's perhaps apathy, a lot of it, whether people at the moment, it could be that we could blame COVID for this, where people just don't, you know, aren't really bothered anymore, you know. So I think you've probably done well to get 172. Do we just take that now on the, did you say 153 comments?
We had 100, yeah, we had of the 172 who responded, 153 wrote something other than just ticking the answers to the question.
Right. So the other 17 or whatever it was, they just tick the boxes, yeah?
Yeah, sent it back, yeah.
People don't seem to mind ticking boxes, do they? But no, I just think it's a very low turnout. Just see what everybody's comments are, really. Thank you, Catherine, anyway.
Thank you. If I could, Chair, with your permission, I could just add one thing that I forgot to say. Yep. We did ask Health Watch to support us with the consultation. So, and we put their telephone number on the letter that we sent with the questionnaire, so that they could, so people could ring them for independent support and advice. And also they did, with people who they came into contact with, encourage them to complete the questionnaire. Sorry, Chair, I forgot to say that.
Thank you, Catherine. I mean, in one way, congratulations that you did get so many back, because I know with the waste management one, we sent out to the whole borough and we only got 200. So in one way, it was a bit of a win. I think, yeah, you put the case over very well. I think, if anything, the current situation has highlighted the carers and what they do. I just want to bring it, Councillor Madoni.
Thank you, Chair. Yes, can I just confirm, I actually thought that response rate was good compared to other consultation. I mean, there's the one that Councillor Ralph mentioned. So I was going to say, well done on that, and ask you what you did differently. Was it the sort of partnership with Health Watch, or was it the way, were you ringing? I think I remember you might have been ringing people. Anyway, to get a bit of feedback on that. Also, well done for picking up on the responses which weren't anything to do with the consultation and actually managing those. I think that's really good and going the extra mile. So well done to all the team on that. Going to the comments and the themes that came up, I mean, individuals felt that they should not pay due to previous taxes paid or working for numerous years. Well, I must say I agree. I find it really sad that the way finance is allocated from central government and how then decisions have been made at the local level, which has impacted council finances, now means that there's this added pressure on finances, which means we've got to go and ask for more money and to raise these charges. Sorry, excuse me, my screen's just gone again. Yes, absolutely. We all value our carers and we all think they should be paid a decent amount of money. So we're all agreed on that. And I must say, some of the comments that said that they had the assumption that the decision had already been made, so there's no point in the consultation. Well, it just goes to show there's no fooling our residents, because here we have a situation where the majority didn't want the raises to go ahead, but it was pretty preloaded that they would be going ahead anyway. So yeah, those are my comments on it really. I think it's very sad that we're having to raise these charges. And I think it's very sad that people feel that they're having to pay twice, which they are having to pay twice. And all the tax that they've paid in over their working lives is not there for them when they get to this stage within the social care system. I just find that really heartbreaking. Thank you.
I understand some of your points, Councillor. I think from my point of view, my comments on this will be, I don't want to go down the financial route of the council. I know what you're sort of aiming at. We would be in a worst case scenario if some decisions hadn't been taken. On this point, I think this is a value. I'm paying for a value service. I think Thurrock takes pride in the care that we provide. The only thing I will pick up on this as a comment is the gap between year 2 and 3. It is a bit of a jump. I don't know if there's anything on there. I think I'm going to leave that till later on. I'm going to bring in Councillor Holloway first.
Thank you, Chair. A question on the practical side of the consultation. So it was sent out via a paper letter. Do we include a stamped addressed envelope, like a self-addressed envelope that they can just use and pop back in, or do they have to provide their own stamp? Is my one question. And then my other point is that, as Roger said, this has come back twice previously. This is the third time. I think everyone has spoken on it and said their views on it. This obviously isn't a decision for Cabinet, as Roger also pointed out. I'm under absolutely no illusion that Cabinet would be listening to what we've got to say about it anyway. I do echo, though, Councillor Muldooney's words, and I just find it so sad that we do have to go out to charge people, and this isn't something that we can absorb because of the financial situation. Like it or not, there's a £30 million hole that was mentioned at the Cabinet meeting yesterday, and that's not just COVID. I don't like seeing charges for anything being put on our older residents than they already have, be it even if we're analysing that they are financially more stable. I just think it's so sad and it's so disappointing that this has to be an option because of the financial situation. And that's aside from the comments that I've made at previous meetings. I'll leave it at that, Chair.
Thank you. Councillor Massey.
Thank you, Chair. A bit of a mixture of other councillors' views on this. I agree with Councillor Redsell. I think that lots of residents feel they're being over-consulted and that some decisions have already sort of written in stone. And to have numbers-wise, when everyone's home with COVID and things, I think would have been nice to get a bit more, but we are where we are. That's the response we've got. I also agree it is quite sad that when we come to this point of life that we are having to pay more. I think it's quite clear that we are at the moment too low. But I think I'm going to go straight to the financials around my question. Year 3 looks quite high. Now, we haven't put these prices up for 4 years. Could we maybe add an extra 4th year in there to smooth out this process and make it less of a bite financially for residents, as we are going to be facing, everyone's going to be facing some really hard financial situations in the next 4 years. There's no doubt about that. So maybe we could make it a little bit smooth of a transition. That's what I'd like to add.
Okay, just before we go any further, we have now hit the 9:15 time limit. I'd like to propose extending the duration of the meeting. I'd like to move a motion without notice to suspend council procedure rule 11.1 to allow the meeting to continue beyond 2.5 hour time.
Agreed.
Thank you. Okay, so our comments are to be noted on. Sorry, Roger, do you want to come in?
So I don't know, Catherine, did you want to answer the point about the prepaid envelope? I think you were nodding.
Yes, no, we did. We put in a free post envelope with every questionnaire so that people could send it back and didn't have to pay.
So, Chair, just in conclusion then, so as Councillor Holloway said, this is a mirror of a report that will be going to Cabinet at the budget setting meeting in February. These are always very difficult balancing act. We have to work within the financial rules that we have as a local authority, whatever our views might well be on them. We need to make sure that we don't put charges up to such an extent that they may deter people from accessing care. That's always the difficult balancing act. I think at the moment, on balance, considering the overall financial position of the council, this is a fair and modest proposal. It will be phased in over 3 years. Obviously, Councillor Massey's as an additional proposal that Cabinet, I'm sure, will consider. But if we don't do this, we will have to find £300,000 from somewhere else. So I think, in view of the place that I think our fair charging policy is a very fair charging policy, we do take into consideration everyone's disability-related expenditure. It is, although it will be an issue, I'm sure, for some of the 265 people, it is overwhelming majority of people, this will have no impact on whatsoever. So difficult balance to get this balance right, but I think phasing this in over 3 years is what we will be proposing to Cabinet. But I'm sure Cabinet will also listen to the views of Scrutiny as well.
Okay, thank you. Councillor Moldani.
Sorry to come back. Thank you for that summary, Roger. Sorry to come back. It's just because you mentioned about people perhaps not being able to take up care with the rises. I can't remember from the report. I can't recall. Maybe it was in there and I've forgotten it, but I just had a little look on my computer. Was that actually a question that people were asked? Would this stop them from taking up, with the rise, if it went ahead, stop them from taking up care?
Yes, it was. It was a question that was asked. It was on the questionnaire, and I think we asked the view: did people consider that this would deter people from coming forward for care if we raise the charge? So there was some options to tick. I can send you the questionnaire so you can see it.
What were the figures on that? How many people said that they?
I don't actually know. I'm really sorry, but okay. I can certainly send that to you. We have an analysis of that. Yeah,
that would have been handy to know. Thank you.
Sorry.
Councillor Holloway.
Yeah, thanks, Chair. I just want to, bearing in mind Councillor Massey's, suggestion of having it phased over 4 years, and the concern about, our comments getting to Cabinet appropriately, whether or not we need to formalise another recommendation that the committee recommend that the introduction phased increase in charging is phased over 4, not 3 years, and that is formally written into the report, because I've seen some of our recommendations and comments not reflected in points that have gone to Cabinet. So not just my committee, but others. So if we can get that in as a 1.4, I know that the Cabinet are looking at across a 3-year budget, but our suggestion, as per Councillor Massey, is that a gentler phasing in So recommend 4.1 for the health and wellbeing overview and scrutiny to committee to recommend an introduced phased increase over 4 years.
Thank you, Councillor. Yeah, as I say, I was going to leave my comment to the end, but that's exactly what I was going to say.
Oh,
So,
sorry,
yeah.
Chair.
No, that's fine. I think if we can all agree on that, Councillor Vettel.
Yeah, Councillor Holloway has just said what I was going to say.
Yeah.
Yeah, I'd like to second that. So I think.
I mean, I don't know if it's going to be a whole working out. It's just for me, my concern was that last gap between year 2 and 3. It just seemed a little bit more too steep. So I think we would reckon that as a 4.1 recommendation of going to the 4 year.
Yeah, Chair. Can I just comment? I don't know whether I'm wrong or right, to be honest, but I don't think COVID affects that broad sort of take of people in that area. Is that right, Roger? That won't affect people that are on a lower income, or I mean, this doesn't really affect people that are working, does it at all?
No, this is it's about how COVID has and other things have impacted on the council's budget. Is the issue, not the individuals.
No. So it's the council budget that's going to affect, and not the people that are in. Yeah, but I still think Councillor Massey's got a good point. Thank you, Chair.
Thank you. So that will be our recommendation going forward to Cabinet. Thank you, Roger.
Agreed.
Okay, where do we get to that? Okay, item 8, accessing GP appointments and Think 111 campaign. The report can be found on pages 31 to 36 on the agenda. Can I ask Mark Tebbs to introduce the report, please?
Thank you, Chair. So I was asked to bring a report on some of the sort of changing aspects of access to healthcare services as a result of COVID. The report focuses on Think NHS 111. We have covered some of the kind of primary care changes in our previous update. We didn't include it in the written report just because it was a very much a kind of change in feast. So I don't propose, due to some of the sort of timing as well, that we go over the primary care aspects, because I think we've already covered that in the previous section. The written report focuses on Think NHS 111 first. The report sets out why the changes were set in place, which was primarily as the kind of need to make sure that our A&E department's waiting rooms weren't full. So the risk of infection through COVID through having full waiting rooms was through the kind of Royal College of Emergency Medicine. They felt that that was a risk that we needed to try to avoid and mitigate. And the proposal was to develop a mechanism where people could book A&E attendances through the 111 system. It's a national rollout. It's a national programme. On page 32 of the report, it sets out the must-dos from a national perspective. So making sure that there's sufficient NHS 111 capacity to do it, making sure that the pathways are clearly set out from that 111, so there are alternatives if that is appropriate, that there is a mechanism for booking patients into A&E, that there is a thorough evaluation and monitoring process, and that there is a clear communication strategy. So those are the requirements for us to go live. We met those requirements and the service went live on the 1st of December. The report just lists out that actually we were very well prepared for mobilisation, because we had a number of those elements which I've just described in place already. There is a description of what the pathway looks like. In effect, people call 111, they speak and go through the clinical assessment service, and if there are alternatives that mean they don't have to go to A&E, then they are put onto those pathways. if they do go into A&E, if they do need to go into A&E, they're booked a time slot. So they've already waited through the mechanisms of making the phone calls, so they don't have to then go into the department and wait around in a potentially environment where they could transmit or contract COVID. So the kind of pathway description is set out in the flow diagram. There is a kind of a very robust evaluation process, both locally and nationally. So patients are kind of tracked through the pathway to make sure that there's no adverse effects. Since the 1st of December, when it went live, we are averaging across Mid and South Essex 57 patients a day going through the process. We have not had any complaints or kind of adverse incidents through that mechanisms. In fact, it's kind of working, it's working well. I think some of the anticipated monitoring has been lighter touch than had been planned as a kind of response to COVID. But the kind of local intelligence we get is that the pathway is working well, that it's being used, and that it is reducing the waiting times and the crowdedness of A&E, which is obviously absolutely critical at this moment in time. So if you are happy, I'll stop there, and happy to take any questions.
Okay, thank you, Mark. As you know, Mark, I was quite concerned when this was rolled out, mainly because on the back of the same week that it was announced, British Heart Foundation of 5,000 extra heart attack deaths during COVID. And my concern was anything to stop people from going to A&E. I think in hindsight now, it was a good decision to do this, seeing the pressure that we wasn't knowing was going to come then, that they've been over the Christmas period, and it's probably taken so much weight off of the end of A&E. I still have the concern that we may be missing things. I don't think that people are generally very good at looking after themselves and can put off going to the hospital till it's too late. So if there is a very good monitoring system in place and tracking these people through when they do eventually contact us, what I don't want to see is you having to deal with more critical people when they do turn up at the hospital after contacting 111. I can throw that open now to, sorry, I do not know who was first, Councillor Redsill or Councillor Madoni. I'll go Councillor Redsill first. No, Councillor Madoni, you ever.
Thank you, Chair. Sorry, I'm not bothered who goes first. Yeah, I've got to say that in this last year, I've had nothing but praise for doctor surgeries. They've been really good. Might have had a few complaints before this, but with this, I think you're right, Chair. We don't hear about all the people that are really good and looking after themselves and sort of self-medicating with little things. It may be a couple of paracetamol or whatever, but I think people on the whole are quite good, and they don't want to bother their doctor in case, it's very serious. But I've had nothing but good coming back from the Chadwell one and the Stifford one. I've only got one doctor's surgery and I haven't had anything from that in my ward. So I think it's very good. They know their doctors have a lot to deal with. So I think on the whole, a bit of praise goes a long way. Thank you.
Maybe Councillor Ralph has frozen, so should we go on to Councillor Muldowney's question, please?
Thank you, Jenny. Yeah, I'm a bit confused about 1.1. The Health Oversight and Scrutiny Committee requested this report. I don't actually recall us requesting the report. So I was a bit puzzled that this report was on the agenda and all those other ones were missed off. But anyway, maybe there'll be an answer about who actually requested the report. Yeah, I've had some good feedback about the 111 programme from local residents, and yeah, it seems like a no-brainer, really. Have a triage system so that our A&E isn't getting overrun at a time when we're trying to do infection control in terms of COVID. So just a bit puzzled on why it's here, really. I suppose what I would ask, sort of as it's come here, is you say you think it's working well. What is the actual? Can you talk us through the actual process of what happens if somebody can't get a GP appointment? They ring 111. Can they actually get a GP appointment through that means, or get otherwise sorted out through that means? I mean, I've had some good feedback about the 111 being able to deal with issues, particularly mental health issues, without a GP surgery visit being necessary. But maybe you could sort of talk us through that process.
Yes, this is more if somebody is planning to go to A&E. The request is that they call 111 first. So the campaign is Think NHS 111 first. So rather than just starting that journey, not obviously if there's a heart attack, if there's, you need to call 999. If you're going to A&E and you can, call 111 first, then you will be assessed over the phone, and the assessment will then direct you to whether there are alternative, better pathways for you to avoid going to A&E. If you do need to go to A&E, they'll book you a slot, so a time slot. So turn up at 9:15. They're expecting you at 9:15, and then you go to A&E, and you don't have to wait around and kind of wait for 3 or 4 hours. You just go in and you go and see, and you're expected there, and then you are seen hopefully within kind of 15 minutes of your appointment time. So it's that's the pathway that we're describing.
Okay, so it's nothing to do with GP surgeries at all then?
So there is, so one of the dispositions, one of the pathways from A&E is the ability to book you into a GP appointment.
Okay, thank you very much.
I've got Rahul and Neil both want to come in on this. I don't know.
Thank you, Chair. I think Marcus already said that. I mean, it's a disposition from NHS 111 to GP surgery. So we do have now separate slots for NHS 111. So they can book directly the patients into that appointment slots. So they'll be seen by GP or telephone consultation now. I just want to say, I mean, in terms of primary care, the surgeries are all open for business as usual. But only thing, the way we work is slightly different. In the sense that it is more of telephone consultation and video consultation and bringing patients when it is absolutely necessary. For 2 reasons. One is that it is for the patient's own benefit because of the situation where we are in now. And the second reason is, as you can understand, the staffing, the level of staffing and the number of surgeries that has gone down with outbreak is huge, in Thurrock especially. So I think it's around 14 surgery was recorded that they have some one or the other person's been positive for COVID. So it becomes slightly complicated. So, but I just want to say that. And the other thing I just want to say, thank you to, I know we have had thanks for the NHS, to thank you to Roger and team actually, the Thurrock Council as such, the way they have worked in social service especially, it is absolutely wonderful. So I have seen the other regions where how the social service has worked with the NHS colleague in organising, for instance, the Red COVID ward, home, for instance. Absolutely brilliant. The hospital can discharge. I mean, that is one of the things that we would love to be in Thurrock, in the sense the way we worked with Roger and team, especially. I think I know Roger for a long period, I think. So I just want to say thank you.
Oh, wow. I would like to say a point on this is that when we come to their GP surgeries, they seem to be very, very quick to stop face-to-face consultation. And a lot of our local pharmacists are still doing face-to-face consultations. And they seem to be taking a massive weight off of the GPs. So our local pharmacists in Stamford and Corringham are seeing all the people coming to them with their joint pains or their stomach problems, where they want to be felt to see if they've got, I know, they feel they may have a lump sticking out their belly or something, and you're getting the pharmacist doing it in boots. I think that's where my concern is that that hands-on approach by doctors is still missing when we don't have that face-to-face there. That a doctor may just notice something that they weren't there for originally, and that does scare me that you could end up with a longer-term problem, moving forward.
Absolutely right, Chair. If I may come back onto that one. I mean, even we miss that. I mean, it's much easier for me to see a patient and deal with the problem than calling them on the phone and think probably this is right. And sometimes they don't understand us, or we don't understand what they have said. But for me, it's much easier to see face to face and make the diagnosis there and treat them. But that's the situation. But the problem is that in general practice, we are faced with a different kind of scenario. For instance, the sick patients who are in the community, for instance, they were not there before because they don't have hospital appointments, they're not running in, they're really, really sick. So we have to prioritize our attention to those kind of people to provide. So it takes away our time. So if we have to see a patient with a lump and we speak to them on the phone, and then we could have an idea, fairly safe to say that. So we could wait, for instance, and not because we don't want to see them, but because we have to deal with the other immediate priorities. That's why. I'm sure it'll come back.
Yeah, I don't think this is the sort of time and place to talk to it. I think that a bit of a discussion around, has this had any impact on early diagnosis of cancers and that sort of thing. I think that's probably a conversation we need to have further down the line regarding that. Councillor Holloway.
Thank you, Chair. I think I'd echo Councillor Maldoni's comment earlier that yeah, I mean, it says that the committee, Health Oversight and Scrutiny Committee, requested this report. Obviously, that's not true. We didn't, and I take it from your comments, Chair, that you did. I am actually quite disappointed to see that we've, some reports have been removed that come yearly and that should be on there, and that this is on there. And whilst I really appreciate the time, Mark, that you've taken to put this together, I do appreciate that. And it's helpful to have it all in one report. It's all information that was out there already. It's a very new system that's come into place. There's not any analysis yet about its impact or effectiveness, because obviously we can't have that yet. So really, I'm just kind of questioning the appropriateness of it coming really whilst, it's got some information in there that was already public. I've got no question on the report because it was already out there and there's no analysis. But my only question is regards, if the general principle obviously is to stop residents from going to A&E, ideally, where they don't need to. I've had a couple of residents recently who have been sent to A&E for blood tests. So they've had an appointment with a doctor either by the phone or in person and have been told to go to A&E for a routine blood test. Is that right? Is that something that our primary care physicians should be instructing people to do? Just go straight to the A&E, when bearing in mind the kind of we're trying to kind of keep people away for their own safety. Is that right?
I think you're absolutely right, and we don't want people to go into A&E, especially during this situation. But there are some patients, when you have a significantly abnormal blood test that need to be repeated on the same day, your only option would be to send the patient to the place where the phlebotomy is available. So during other hours, we may not have the phlebotomies open, and therefore we would probably ask them, suppose for instance the potassium is significantly high, we have no option to leave that patient for next day. So it comes back to the risk of that patient patient may have. Otherwise, I wouldn't think any GP would send the patient to A&E for routine blood test. Very unlikely.
Okay, thank you for that. Yeah, I'm a bit puzzled why that would have happened, to be truthful. while we're talking about blood tests, Councillor Holloway, do you remember? Obviously, we had the situation with the bus route outside Basildon Hospital. Unfortunately, that's come back again, and we will be chasing it, and we are getting letters sent out, joint letters between us and Basildon to the bus company, and we'll keep us updated on Scrutiny. We had 2 hour people staying outside for 2 hours. Obviously, it wasn't much of a problem when it was warm, but now it's getting cold. It's a big issue, and we can't have that carrying on. So we are changing that right now. I know it's something you're quite passionate about before, so we want to get on to that.
Appreciate you raising it. Can I just come in? I wonder, Chair, if I could suggest that possibly putting out a press release for some public pressure, because it is just morally unacceptable at any time, let alone during a pandemic, where a bus company has decided to reduce its service. Now, look, I understand that they probably have similar workforce issues, but this is an issue that was even before COVID. So, you know, if there's any press release that you'd like to draft and put out, you know, and many emails that can be sent, happily share the contact details that you have, and we can get multiple letters sent to them if that would, I think that might help put a bit of extra pressure.
Yeah, I think obviously the letters before didn't work. So this will be our first approach. It's going to be the joint letter with Basildon. But we will keep the pressure on, and if it means that we go to a press, then definitely anything to get this rectified. Councillor Maldoni.
Yeah, thank you for raising that. Just because you've raised that, I'd just like to mention that it was reported to me that the buses mentioned in the information leaflet for the Stifford Clays vaccination centre was wrong. Apparently there's only the 88 that runs there. The other buses that were on that information sheet are actually school buses, and they're not running obviously because the schools are not in at the moment. So if that could be communicated in some way, and that 88 bus is only one bus an hour, so it's quite difficult, isn't it, for people who don't drive, especially when we're anticipating that, well, we're vaccinating the over 80s and then the over 75s and then the over 70s. They're probably going to be a significant proportion of those that do rely on the bus service to get there.
Yeah, it's a good point, really. I mean, perhaps we should have spoke about this earlier, that how much was it looked at, the bus service, when they picked those locations to do the vaccines. Councillor Ritzer.
Only wanted to say, Chair, that I chair the bus user group. So if you want to come through me for anything, and I can help with most of the bus companies, I'm quite willing to do that first before you perhaps put a press release out. You know, we can go to them and say, so if you want to send me an email about it, then I'll go to the bus companies. Okay.
Yeah, that'd be great. Thank you.
Cheers.
Okay, Councillor Maldoni, you still got your hand up?
Sorry, that was just left up from before.
Right, okay. Where we get to now? Verbal update on Orsett Hospital IMCs. Can I ask Roger to give us an update on this?
So unfortunately, again, mainly because of COVID, neither Tom, Abel, nor Margaret Hathaway are able to come here tonight. So, but they have. I am aware of what the position is. So I've got a short briefing. I'll just give you some of the highlights from that. So they reassure us that the Mid and South Essex Trust remains committed to the long-term closure of Orsett Hospital and has agreed at their board meeting they continue to fully support the programme to develop the 4 IMCs, and they agreed the programme business case at their meeting in December. Prior to COVID pandemic, they had already started a detailed mapping exercise to inform the locations of where all the services from Orsett Hospital will be transferred to, and they remain committed that all services at Orsett Hospital that are servicing Thurrock people will be relocated in all the IMCs. It was intended It was paused in the early part of the pandemic, and it was intended to restart this position in January, but because of the second spike, that hasn't happened, and they're going to review the position again in March. Obviously, Alston Hospital has been utilised for some of the non-COVID services from the Basildon Hospital site, to allow to try and maintain Basildon Hospital site has been largely used as a red hospital site, but has also given them an opportunity to see whether an increased range of services, more outpatients, more diagnostics, more minor procedures could be taken off from the Basildon Hospital site. So in a way, it actually has, if anything, increased the likelihood of more diagnostics, more outpatients coming off Basildon site and moving into the integrated medical centres. So the intention is that the principal location for Orsett services will be at the Grays IMC on the Thurrock Hospital site, and the plan is that hopefully, again, this is all slightly dependent on getting over the current peak of COVID problems, that the planning will start again in detail March, April time. So that was a statement from Margaret and Tom. So I think overall we can take from that is that the planning has had to be paused. They remain committed to the whole IMC programme, but because of COVID, it hasn't been able to progress much further, but we'll start again hopefully in March and April.
Okay, thank you, Roger. First of all, there is some good news that the construction work has actually started on the one in Corringham. So they've actually been up there, started digging. So spades in the ground has actually happened. I know that was promised to start in January, and it has happened, which I was quite surprised about because I really thought that was going to get pushed back again. So that is encouraging. Obviously, we do have concerns over what's going where and all this. I would like to see the new drawings for the one in Corringham, because I do understand that they must be on the line somewhere because they've got a new entry point and they've taken over control of the private road to the school. So again, that's encouraging. I think that's solved the problem now. I think the Tilbury and the Grays hub does concern me. I think on the whole, through this pandemic, if we've learned anything, it's the need for more beds in hospitals. And maybe, we keep saying it, a new hospital. I know with our growing population, we keep building, and with COVID, with new hospital comes new staff. And I just think that, we've got to take this and learn from it. And for the future planning of our borough, not having its own hospital, I think there's got to be, it's got to be something that's got to be addressed. Councillor Holloway.
Yeah, thank you, Chair. The reason why we asked for this verbal update was obviously not a general update. It was specifically about, an Orsett specific update. Can I suggest, bearing in mind, so that we just don't have the same update each time, to save Tom and Roger, you reading it out and us just getting the same thing. We've had nothing new on the update. I understand it's because of COVID, that's fine. Can I suggest that we don't have any more verbal updates until there's something new, because it's just wasting the committee's time at the minute. I completely understand that they're not doing it. Can I suggest that it's brought back in the new municipal year, because obviously I don't think there'll be a written report available for March, because I don't think this obviously the pandemic and all of the fallout from the pandemic won't enable them to do a detailed proper report for March committee. Can I just suggest that this gets pushed back into early municipal year so that we don't spend any more time getting the same information?
I concur with that. That's I think that we never knew that this would get pushed back so much, and we was hoping for a written report. It's gone to a verbal report. And again, for the right reasons, it's not moved forward. Better time spent elsewhere. So yeah, if we can move that on, we'll move that on to the next one. Moving on to the work programme, I believe, aren't we? Is that the last one? Yep. So moving on to the work programme, we can move that one off of the next one. Councillor Holloway, you said about the men's health domestic violence. Yeah, you're right, because I'm a bit of a puzzle over this, because there is work going on behind the scenes of trying to get a more attention brought to having something in Thurrock or in the southeast of England where men can go that are escaping. And you're probably right, it's not something that solely sits within our spectrum of what we cover. But when it comes to sort of domestic abuse and all that, it's something that I think that we do need to do sort of a bit of work on it. It's probably something I'll go away with and work on and bring it back at a later point.
Yeah, I think that the point I was trying to make, Chev, wasn't that it was on the work programme, not a problem to have it on the work programme. It was just to be clear from the minutes, very clear what we've agreed and what we've discussed and what we haven't, and we didn't technically agree it. Can I suggest perhaps that, bearing in mind the domestic abuse now bill, hopefully act, will be an act by the new municipal year, that we bring back, where officers are able to do this, I don't want to add to the workload, but hopefully once things have calmed down, that we can do an analysis of the service and what the impact that the Domestic Abuse Act will have. And as part of that discussion, you might be able to bring in an update during that time, if that's deemed appropriate.
I think that's an appropriate step of action. Obviously, during this lockdown, there's been a rise in domestic cases as well. So there is work going on. They're busy doing their stuff. They haven't had time to produce the stuff I've asked because of COVID as well. So it may be a time to sit back, reflect, and work on that and bring back when the new law is passed. Okay, Roger, looking at this work programme and the things that have been moved about, do we anticipate things being dropped off for the next one?
I can't give you a definite answer one way or the other on that one. I mean, at the moment, the work programme looks quite light for March. There is still a list of items that, as you know, have been deferred. So obviously, you can see on the prospective 2021-22 work programme, obviously the obesity strategy outcomes framework and the personality disorders complex needs project reports are still there. I think I'm sure you will get there's already a COVID update in the next item and the next report. I think it's a little bit early to say. I suppose it depends a little bit on how the pandemic develops over the next few weeks and the next couple of months. I don't know if there are any other items that members wish to see come forward. Again, with the health warning, we need to just bear in mind about time to write the reports. But if there's any other items that members wish to bring forward, we could put them on the, if you like, the long list for the work programme.
I do believe in March, didn't we ask Basel Hospital to come back and present the maternity report?
Yes, that's on there, Councillor Ralph, on the last page.
Should be there somewhere.
Because I ain't got my glasses on.
Yeah, it's on there.
It is there.
Yeah, it is. I do apologise. Kaz Holloway, do you want to come in?
Yeah, I just wanted to make doubly sure that there is a couple of the reports on there that were supposed to be on tonight's agenda that have been put onto the next year's work programme, just to capture all the ones that weren't on there as well. So obviously the worklessness and health JSNA, the strategic safeguarding plan, just to make sure that those are on there as well. And again, just to have it written down in black and white, because I think that's really important. We do want a report, we do want a presentation, and we do want to hear something back from Cambridge.
Yeah.
So I expect to see them next month. I expect to see someone. And the only other thing I would put for the long list for at some point next year, which I'm sure, again, officers will already be doing, but again, just so it's written down in black and white, obviously the impact on many of the services post-COVID, when we hopefully have more people vaccinated, to get an overarching view that many of the services will have changed, many of the demands will have changed, many of the work that should have happened has been postponed. So an overall, where we're at with everything in some of our really kind of key projects, domestic violence, sexual violence being one of them, obviously, that I've kind of taken an interest in. So that at some point in the new municipal year as well, as soon as the public health team are, finished dealing with our pandemic.
Let's hope they are finished with thing with our
We
pandemic.
hope.
They need a good break at the moment.
Definitely do.
Working them too hard.
It's not going to end anytime soon. Sorry.
Don't tell Roger that.
Well,
It isn't though.
It will for Roger.
it will. It won't be me after that. Will be my last
No.
next one.
You'll still be watching, Roger. Don't worry.
He'll be sitting up with pipe with slippers.
Yeah.
Have you had your vaccine yet, Roger?
That's very unlikely.
Okay, so time is 9:54, and I'd like to call the meeting to an end.
Okay. Keep safe, everybody.
And
Good
you.
evening.
Thank
Thank
you.
you.
Bye.
Bye. Bye.